Good morning, friends. So we are again for another CME in the month of October. After a very good response for your 11th October CME, we are going for another CME. We got six speakers today, and we will not waste much of time. And I'll just hand over the mic to our secretary and Master State Secretary, Dr. Pankaj Bandarkar. Over to Pankaj.
Thank you, Anil. I welcome you all on behalf of IMA Mumbai branch. Honorary President Dr. Sujatul Nissa Attar and today's eminent speakers Dr. Ashok Mahashur, Dr. R.B. Patak, Dr. Ian Pinto, Dr. Suresh Advani, Dr. Paresh Vaid, Dr. Vaibhav Bagaria. I welcome you all on behalf of IMA Mumbai branch. Friends, we have adapted well now to this web platform CMEs and we are getting good response from all of you. Our next CME will be on 15th of November, which is a World Diabetic Day. So do attend that and register in advance. One more thing is we will be having Maharashtra State Council meeting at Solapur. So all our members who wish to join for this and come for this meeting, please contact our office so that we can do advance bookings. Friends, all of you know that Dharavi pattern note was taken all over world, and now World Bank has also taken note of this Dharavi pattern. Dr. Uture and Dr. Anil Pashnekar, who are our members. Dr. Uture is an MMC president, and Dr.
फेस
Anil,
बरोबर
Pashnekar is a immediate past vice president. They have worked very hard. We congratulate them. Now, without wasting much time, I hand over mic to Dr. Sujatul Nissa Attar, our honorary president, to deliver her address.
Thank you, Dr. Pankaj. Good morning, friends. Happy Navratri to all. In this COVID pandemic era, we are having our CME through webinar, and this is the new normal now. We have 6 eminent speakers who will share with us their vast experience in their respective fields and enrich us to how to deal with such cases. Friends, one more thing has happened in this COVID area, that we have learned to be tech savvy and to join CME through various platforms like Zoom, Microsteam, Google, URL, and all that. And without wasting much time, I now hand over the proceedings to our Assistant Director, IME CGB Mumbai Sub-Faculty, Dr. Anil Awad. Over to Dr. Anil.
Thank you, President Madam. We'll begin with the program. To start with, we have Mr. Dipen Mehta, who is with DigiShield. And DigiShield, as you know, has been our sort of a knowledge partner for throughout this web CMEs. Dipen Mehta is the COO of DigiShield. He carries a decade-long experience in operating and controlling critical business processes in the field of financial services, healthcare, and pharmaceutical. I request Dipen Mehta to start his talk.
Thank you, Dr. Anil. Thank you, IMA Mumbai, for giving DGCL as an opportunity. I will just not waste your much of time. We'll start my session. It's like only 5 to 6 minutes. I will just have a go through of importance of digitalization for the doctors in current COVID situation and how digital can help doctors to digitalize their clinic, digitalize their prescription. So like as you can see in current situation, many of the doctors have moved to digitalization, but still in India, 80% of the doctors are yet to convert their clinic prescription into digitalization. They are just used to prescribe the medicine in their traditional way, writing the paper, writing the pen, and hand over the physical copy to the patient. So the reason is there are various other challenges which doctors are unable to implement digitalization and unable to maintain their medical records. The first and the most important thing is the cost. It requires huge capital investment cost to purchase computers, laptops, printers, server, internet. Then there are lots of standard exchanges issue. Like many of the softwares available in the market are in the English language, and like doctors in the village area or the poor areas, which doctor unable to have the prescription in the language which they want. So which also faces difficulty for the patient, because like in the villages, poor area, the patient are unable to understand the prescription in the English language. It requires huge computer knowledge or tech savvy. So like doctor are not much of tech savvy. They are just used to with their traditional method. So it requires also a huge cost to implement the EHR in training. Their existing workflow also gets spoiled. So the computer literacy is also one of the major thing which doctor faces to implement the EHR. uh, there are no policies such maintained by the government. There are no standard formats. It also requires huge infrastructural cost, and also doctor are worried about the privacy, about their data. How is their data safe? Is their data secure? So all these challenges can be solved by the DigiShield. So is there a solution for this crisis? Are we in position to restart India's healthcare system safely and effectively? DigiShield. So we have also created one AI-based solution in which doctor can have access of their patient's health, and like if patient wants to visit in the in-person consultation, so before that through our AI-based solution, the doctors can get some basic idea of the patient, like whether patient is of high risk of COVID, low risk of COVID, or moderate risk of COVID. So at the time of booking the appointment, patient will receive one SMS link in which patient has to mention their uh, location history, their comorbid diseases, whereas 17 to 18 parameters are there. After inserting the all these parameters, our AI-based analysis the health record of the patient, and it gives something information to the doctor whether the patient is of high risk or low risk. If suppose the doctor is if the patient's result shows something as a high risk, so doctor can do a teleconsultation. If patient is having low risk of medium risk of COVID, and patient has to visit in for in-person consultation, then doctor can book their appointment and have patient to do in-person consultation as well. So what we focus the security. So Digicil is a HIPAA compliance company. So the data of the doctors, medical records, everything has been securely stored. The doctor can access their record and whenever they want, and whichever location they are into. They just need to have their login ID and one-time OTP generated password to log in the application. So it's very convenient for the doctor to have their patient's record on the go. Doctor can get the analytical reports of their patients monthly, weekly, daily, about their diseases, about the patients uh, uh, consulting fees, their financial thing. Every analytical report can be viewed by the doctor. It helps doctor to maintain relationship with the patient by maintaining the record accuracy of the records, and the records are securely stored in the cloud server. If doctor's phone or tablet has been misplaced or has been broken, so like the doctor can have their login ID and can insert their login ID in the new devices, and they can have their records on the go. Many times it happens that doctor write the paper prescription and sends the prescription to the patient, and have the patient to follow up after 2 3 days. So like after 2 3 days, patient forgets their prescription. So in such cases, it's find difficult for the doctor as well to give them further medication. But through DigiShield, once doctor writes the prescription, they click the photo and they upload into the application. Patient will receive the soft copy as well. So like if a patient forgets their paper prescription even for the next visit, doctor can view the entire history, entire medical records, everything can be viewed by the doctor. Even doctor can do teleconsultation, video consultation, health pay, online appointment booking. Then the doctor can even upload their patient's medical record, medical history, everything can be uploaded. Patient will also receive the reminder, uh, appointment reminder as well. If suppose doctor has scheduled the appointment on say 25th of October, so like on 24th of October, patient will receive a reminder SMS as well that you have a visit tomorrow with so and so doctor at so and so time. So many times even it's happened that doctor are doing currently video consultation through WhatsApp, but there is a risk for the doctor. What if patient doesn't pay the consulting fees, or like how to ask the patient to pay their consulting fees? And suppose doctor has done consultation through WhatsApp and doctor has sent the prescription, everything is process is followed, but the consulting fees is pending. So through DigiShield, what advantage doctor has? Even like a doctor has done the consultation, a video consultation, doctor has sent the prescription, but patient has not paid the consulting fees. So the prescription would be not generated for the patient. The prescription only will be viewed by the patient once the patient makes the payment. So patient will receive one SMS link of the prescription once doctor upload the prescription. So patient has to click the prescription link, and it will prompt the patient to make the payment. So once the payment has been made by the patient, then only the prescription would be viewed by the doctor. And DigiShield is very easy to use. Just need to have one-time registration of the patient. Once patient is registered, doctor can do teleconsultation, video consultation, upload prescription. Patient will receive the soft prescription as well, and patient will receive the reminder SMS of their follow-up visit as well. So it's very easy to use. I would request doctor to start downloading it from Google Play Store as well as from iOS App Store. It's free for the doctor for the lifetime. So would recommend doctor, if they are not using any digital health platform, so start using through DigiShield. It will help doctors to maintain their medical record of their patient as well. The number of times the patient has been visited, what are the previous medical records of the patients. Everything can be accessed by the doctor in the one go. If you have any issue, you can contact us, or you can also visit our website www.digishield.me. If you have any query, you can also post your queries in Q&A session. Thank you. Hand over to Dr. Anil.
Yeah. Thank you, Dipen. I'm sure digital will be a very useful tool in the era of telemedicine. And now we begin with our academic session. And the first speaker today is Dr. R.B. Pathak, sir. I'll just introduce sir in brief. Dr. R.B. Pathak is a consultant diabetologist at Raija Fortis Hospital, Mahim, and Srimati Motiben Dalvi Hospital. He did his MBBS and MD internal medicine from the prestigious St. GS Medical College and KM Hospital. He then worked with senior diabetologists like Dr. J.C. Patel, Dr. N.G. Talwalkar, Dr. S.S. Ajgaonkar, Dr. B.S. Raheja, Dr. B.S. Ajgaonkar, Dr. A.S. Godbole, and Dr. H.B. Chandalia at S.L. Raheja Hospital. He has published several papers in India and abroad and is a member of prestigious medical associations. He is associated with API Textbook of Medicine 9th edition as a member of editorial board. I request Dr. Pathak to begin his talk on effective cardiometabolic treatment beyond metformin. Over to Dr. Pathak, sir.
Thank you, Dr. Awad, sir. I wish all of you a very good morning. I would
Good
like
morning,
to
sir.
thank IMA team, Mumbai, Sajatun Nisa, Attar Madam, Bandarkar sir, and Awad sir. I would also like to extend my thanks to MSD team for all their help they have provided me. Today we'll be discussing about two of the most popular and currently available oral antidiabetic agents. Oral antidiabetic agents which are very commonly used these days, precisely DPP-4 inhibitors and SGLT2 inhibitors. Usually the question comes after metformin, what next? And of late, DPP-4 inhibitors and SGLT2 inhibitors are being used more and more in clinical practice. But the practitioner needs to select the best class of drug for an individual patient based on efficacy, durability, safety, and tolerability. Though practitioners are moving towards an aggressive treatment strategy with multiple medications, the safety of these drugs is also very important. Let us have a look at the world authorities or the world associations, what they say about these two agents, mainly SGLT2 inhibitors and DPP4 inhibitors. As long as SGLT2 inhibitors are considered after metformin in presence of type 2 diabetes, if you have atherosclerotic cardiovascular disease which is established or the patient is having high risk, SGLT2 inhibitors are preferred in presence of heart failure, chronic kidney disease with these specifications. If they do not have an established atherosclerotic cardiovascular disease or CKD, no class is given any special preference and patient considerations will decide the choice of therapy. We'll have a look at the Canadian guidelines which are given in 2018. Patients who have clinical CVD will have diabetes mellitus only in about 15 to 20% of cases. And in those cases, if you have established cardiovascular disease or high risk presentation of a patient, one can use SGLT2 inhibitors. Now, what are the guidelines for early combination and why do you want to do a combination therapy in these patients? Initial combination therapy with metformin with a second agent usually helps in bringing down the HbA1c by about 0.4 to 1% and a relative 40% higher chance of achieving HbA1c less than 7, which is the ideal accepted after 6 months. In comparison to metformin alone, if we add a second agent, it should be chosen on the basis of individual patient characteristics, efficacy, and safety profile of other agents. DPP4 inhibitors and SGLT2 inhibitors along with GLP-1 receptor agonists should be considered over other anti-hyperglycemic agents because of less associated hypoglycemia and weight gain. GLP-1 receptors are available as injectable agents and then they cannot be given orally. So as to simplify and make your treatment safe, DPP4 inhibitors and SGLT2 inhibitors will help to make simple oral regimens, no negative effect on the weight, rare risk of hypoglycemia when used, and low GI tolerability issues and proven cardiovascular safety with enough data available now. After metformin, SGLT2 or DPP4, what are the determinants? Mode of action. This is very important to know how it works in the altered pathophysiology of type 2 diabetes mellitus. What are the determinants of glycemic control? Baseline HbA1c, age of the patient, and estimated GFR. What will be the aim of your treatment when you are using these two agents? You have to maximize the cardiovascular benefits of SGLT2 inhibitors. What are their extraglycemic effects and what are their safety profiles? What is very important is you must know when not to use these two drugs because that is where you will not make a mistake, and in our Indian setting, which drugs will work better. It is not mandatory to choose either SGLT2 or DPP4 inhibitor. If a patient can tolerate a combination, they can also be given in combination along with metformin. This is a very important presentation. One must see. This tells you how these two agents work in a type 2 diabetes mellitus patient who is recently diagnosed or even otherwise. There are parameters on the left side. You see beta cell dysfunction, DPP-4 inhibitors and SGLT2. You see SGLT2 inhibitors do not have any direct action on the beta cell function, whereas DPP-4 inhibitors, they directly target beta cell function and mass. It improves the early beta cell response and they are effective even when beta cell function is poor. Glucagon secretion and dysregulation. It regulates the glucagon secretion. DPP-4 inhibitors regulate the glucagon secretion in both hyperglycemic state and hypoglycemic state, whereas SGLT2 inhibitors, they increase glucagon levels and stimulate its secretion due to compensatory glycosuria. Hepatic glucose production. It inhibits the hepatic glucose release through hepatoportal GLP-1 receptors, whereas SGLT2 inhibitors, hepatic glucose production shown to increase as a response to renal glycosuria. Insulin resistance, DPP-4 inhibitors improve the insulin sensitivity, whereas SGLT2 inhibitors have no direct effect on insulin resistance. And DPP-4 enzyme activity, DPP-4 inhibition attenuates the endothelial dysfunction, inflammation and atherosclerotic process, whereas SGLT2 inhibitors will have no direct effect on DPP-4 enzyme overactivity. Lastly, SGLT2 upregulation and renal glycosuria. DPP-4 inhibitors reduces the renal glycosuria secondary to glycemic control, whereas SGLT2 inhibitors increase glycosuria, which is the primary mechanism for achieving the glycemic control. In type 2 diabetes mellitus, DPP-4 enzyme is overactive in diabetes and SGLT2 enzyme is also upregulated in type 2 diabetes mellitus. Now, DPP-4 activity is found to be significantly higher, and to have maximal glycemic benefit of these agents, it can be achieved when DPP-4 activity is blocked by at least 90% over a period of 24 hours daily between the daily doses. This is just to show you how DPP-4 stays uninhibited at the end of 24 hours after a single highest approved dose of gliptin. If you use vildagliptin as a single dose, about 70% activity will remain uninhibited after 24 hours. Teneligliptin 40% will remain uninhibited, saxagliptin 25%, linagliptin 15%, and when you are using sitagliptin, only about 8%, that is less than 10% activity will be inhibited, will remain uninhibited after 24 hours. So it is only sitagliptin of all the gliptins keeps 90% or more DPP-4 enzyme inhibited after single dose in the morning. More than 90% DPP-4 enzyme inhibition over 24 hours is also possible with vildagliptin, but if administered every 12 hours. Now, SGLT2 or DPP-4 inhibitor, when glycemic efficacy is considered, which DPP-4 inhibitor and which SGLT2 inhibitor are we talking about? What is the dose of SGLT2 that we are talking about? What is the baseline HbA1c that we are considering when you want to use these drugs? Are we talking about patients with an EGFR more than 90 only, or are we considering elderly patients? These are all the questions that should come to the mind of a practicing clinician. Now we compare sitagliptin with SGLT2 inhibitors. Sitagliptin we take as a group representative because it is maximum evaluated. It is not inferior to the usual dose of SGLT2 inhibitors. It is also not inferior but not also superior. It is equal to usual or lower doses of SGLT2 inhibitors and can be used as an add-on to metformin. Impact of baseline HbA1c on the efficacy of SGLT2 and DPP-4 inhibitors. If you see HbA1c less than 8%, DPP-4 inhibitors work much better. When the HbA1c is above 8.5, the SGLT2s will work better in reducing the hyperglycemia. SGLT2 versus DP4 as an inhibitor, once the HbA1c is more than 8.5, SGLT2s will work better, whereas once the HbA1c is less than 8.5, DPP4 inhibitors will work better. Gliptins and gliflozins, that is SGLT2 studies in elderly. If you look at sitagliptin, which is a representative of all the gliptins, it works in all the stages at all age groups. Even in elderly people, sitagliptin will give you good results in smaller doses also. Whereas if you consider canagliflozin, which is a representative of SGLT2 inhibitors, as the age advances, the efficacy of this drug will reduce. We will see why it happens. But as age advances, people are more elderly, beyond 65, 70, the efficacy may not be 100% when you are using SGLT2 inhibitors. Efficacy reduces as age progresses. Here you see that there is a downward trend in the efficacy as the GFR reduces from 30 to 60 to less than 30. This happens because GFR decline begins at the age of 30 to 40 years, and with an apparent acceleration in the rate of decline after the age of 65 to 70 years, the response to SGLT2s will be less as compared to what it was when the GFR was above 60. All three doses of sitagliptin are effective even at a lower GFR. Once your GFR starts reducing, you have to reduce the dose of your gliptin from 100 milligrams to 50 milligrams, and once the GFR goes down further, you have to reduce it to 25% of the dose, that is 25 milligrams. But even in presence of reduced GFR, this particular gliptins will show their efficacy, and all three doses, 25, 50 and 100 milligrams, will be efficacious and control hyperglycemia in such patients. There are no apparent changes in the control of glucose depending on the baseline renal function. Only precaution is you have to reduce the dose by 50% or 25% depending on the creatinine and GFR. Empagliflozin, influence of renal function on A1C. This study shows that as the GFR reduces from 90 to 60 to 30 to less than 30, the efficacy of SGLT2 inhibitors reduces because they usually work on the presence of ultrafiltration rate of the renal mechanisms. You see here that whatever efficacy was seen of SGLT2 in presence of GFR more than 90 or 60 will not remain once the GFR goes down to 30, and in fact less than 45 or 30 GFR, they are not indicated, which we will see in subsequent slides. SGLT2s lose over 50% of their potential efficacy when GFR is reduced to less than 30 ml per minute. Sitagliptin is significantly more effective than dapagliflozin even in mild renal impairment. About 90% have received higher dose of dapagliflozin in these studies, but still gliptins are more effective in mild renal impairment. This is the staging of SGLT2s and DPP4 in presence of GFR and CKD staging. Here you see SGLT2s are not recommended in CKD stages 4 and 5. Once in stage 1, GFR more than 90, sitagliptin very effective. You go to stage 2, 3 and 3B, sitagliptin is superior to SGLT2 inhibitors, and even in stage 4 and 5, sitagliptin is effective but at a 25% of the dose. In 30 to 60, you have to reduce the dose to 50%, and whereas in stage 4 and stage 5 CKD, SGLT2s are not indicated. After metformin, SGLT2s or gliptins, where only efficacy is consideration, you have to consider overall type 2 diabetes population. It is as effective as usual dose of SGLT2s. Second point, see the HbA1c whether it is above 8.5 or less than 8.5. Less than 8.5, SGLT2 efficacy is lowered due to lower ambient glucose, and gliptins are usually numerically more effective in this population. CKD, I have already explained that gliptins may be significantly more effective in SGLT2s. In elderly population, the same reason gliptins are more safer than SGLT2 inhibitors if the GFR is less than 60. Now, cardiovascular benefits. I have told you both these agents, SGLT2 inhibitors and gliptins, are wonderful agents. They have withstood the test of time, and SGLT2s are excellent in maximizing the cardiovascular benefit. Some SGLT2s are only oral antidiabetic agents indicated to reduce the cardiovascular events as mortality and heart failure in type 2 diabetes patients with existing atherosclerotic cardiovascular disease. Empagliflozin, dapagliflozin, canagliflozin also proved CV safety in patients with history of CVD or patients at risk of high cerebrovascular disease. Gliptins, on the other hand, have also proved cardiovascular safety, exception of saxagliptin showing a significant increase in the risk of heart failure, which was later on proved to be statistical and not seen in clinical practice. All these benefits of cardiovascular safety are, of course, after the control of blood glucose. Control of hyperglycemia comes primary, and then this becomes an additional advantage. This is only a snapshot of cardiovascular safety outcome trials. Here you see empagliflozin, canagliflozin, and dapagliflozin. They are all showing very good result in the dark green shade for hospitalization due to heart failure. Major adverse cardiovascular events and cardiovascular death, empagliflozin and canagliflozin have both shown significant benefit in all these trials. Comparisons sometimes confuse because there are different baseline HbA1cs, different HbA1c reduction, different primary and secondary endpoint. So many times these comparisons may confuse, but if you understand the drug properly, you will not make a mistake when you are prescribing to your diabetic individual. If you see 100% diabetic patients, only about 20% will have cerebral coronary vascular disease or a cardiovascular disease, and another 13% will be having only CVD without CKD. So about 30-35% of your patients of these 100% diabetic subjects which you see will have the atherosclerotic cardiovascular disease, and in these patients SGLT2 inhibitors will be preferred if there is presence of heart failure or CKD, provided, that's very important, provided your GFR is adequate. There are a few questions when you are using these drugs. Were any atherosclerotic cardiovascular events significantly reduced by SGLT2 inhibitors? The answer is emphatically yes. They have reduced, definitely useful in reducing the cardiovascular events. Is the reduction of CV mortality significant in only EMPA? No, it is significant in all other SGLT2 inhibitors, and the effect is a class effect. Whether it is significant without history of cardiovascular disease is debatable. There are more studies required, and you will know. Yes, is a reduction of heart failure expected in patients without history of, still debatable. They have to have a history of IHD or an heart failure to have benefit of SGLT2. More studies are required whether these drugs will be effective without history of cardiovascular disease. And is there a particular type of patient with CV benefit can be maximized? We'll see that later on. The next slide will be covering everything. CV mortality, reduction with empagliflozin. Where was all that significant? So which are the patients will be benefited by SGLT2 inhibitors? Glycated hemoglobin should be above 8.5%. Person should be above 65 years. Male patients, body mass index less than 30 BMI less than 30, people with coronary artery disease, or people with 2 to 3 significant cardiovascular risk factor categories. For maximizing benefits in cardiovascular disease with empagliflozin, which is a representative of SGLT2 inhibitors, you must have a history of atherosclerotic cardiovascular disease and an elderly male, not very obese, with a mild renal impairment, wherein the GFR is not less than 30 or 45. What are the extraglycemic effects of SGLT2 inhibitors and DPP4? SGLT2 inhibitors are associated with weight loss because of their caloric loss of glucose, whereas DPP4 inhibitors have some effect on the appetite regulating metabolism, and that is how they reduce the weight a little bit. But neither SGLT2 inhibitors nor DPP4 inhibitors are indicated for weight loss as a primary effect. Sitagliptin also has an effect on leptin and adiponectin, but still it is not indicated as a primary treatment for weight reduction. Sitagliptin also not indicated for weight reduction. Extraglycemic effects of SGLT2s and DPP4 on blood pressure, they do it differently. You have antihypertensive effect of SGLT2 is due to effect on the blood volume, diuresis and natriuresis. In fact, when you are using these drugs with a diuretic, you have to reduce the dose of diuretic to prevent hypotension and hypovolemia. Sitagliptin has an antihypertensive effect in a different way, independent of glucose lowering, but still neither of these two agents are indicated for blood pressure lowering. Now, first, do no harm. You must know when not to use these drugs. Comparison of safety profile of DPP4s and SGLT2s along with metformin. Metformin I will not discuss because you all know where it should be used and where it should not be used. DPP4s one should not use when there is a hypersensitivity reaction, and there are no boxed warnings for DPP4. SGLT2s, again, if there is a hypersensitivity reaction, should not be used, and in severe renal impairment where your GFR is less than 45 or 30, one should not use SGLT2 inhibitors. Boxed warning, canagliflozin carried a box warning of increased risk of lower limb amputations, but now with further studies that risk has been allayed, it does not cause that. What are the other problems associated with DPP4s and SGLT2? DPP4 saxagliptin was theoretically supposed to increase the risk of heart failure. Vidagliptin should not be used in presence of severe hepatic impairment. Teneligliptin should be used in caution with patients with arrhythmia, bradycardia, IHD because of the effect on the QT prolongation, especially when you increase the dose of teneligliptin from 20 to 40 or anything above 20, the QT prolongation may be present and you will have arrhythmias. And what are the general toxic effects or the adverse reactions of DPP4? One, it can cause pancreatitis, it can cause renal failure, it can also cause hypoglycemia along with sulfonylureas and insulin, and it can cause hypersensitivity reaction. It can also cause arthralgias, which are severe and disabling sometimes, and you have dermatological serious reactions. No clinical studies establishing conclusive evidence of macrovascular risk reduction. SGLT2s inhibitors, canagliflozin and bone fracture, dapagliflozin and bladder cancer. We have not seen that as yet in clinical practice, but there may be some isolated reports. What you generally see with the SGLT2 inhibitors is hypotension due to volume depletion, especially in hypertensive patients on other antihypertensives, ketoacidosis regardless of blood glucose level, and acute kidney injury due to hypovolemia and hypotension. Usually they have euglycemic ketoacidosis. Urosepsis and pyelonephritis is a dreaded complication of SGLT2 inhibitors, and one also has to be very careful for that. Sometimes necrotizing fasciitis of the perineum like Fournier's gangrene can be seen. Very commonly seen genital mycotic infections if proper care is not taken, and hypersensitivity reactions and increased LDL listing. The use of SGLT2 inhibitors were associated with higher risk of infection, osmotic diuresis, volume depletion effects, renal related adverse events, and higher blood ketone bodies when compared with placebo. Genital infection risk is definitely more with SGLT2 inhibitors, and if proper care is taken and hygiene is followed, the risk can be minimized. But in a warm and humid climate like our Indian weather, these infections do pose a significant risk, and if patient is getting this, you have to withdraw the drug. Patient will not tolerate them. Choosing SGLT2 or gliptin, are there India-specific considerations? Efficacy of SGLT2 is similar across the races. Gliptins are more effective in Asians and significantly show better efficacy than Caucasians. Some adverse events with gliptins, SGLT2 inhibitors, may occur more frequently in warm and humid climates, and adverse events with SGLT2 may require urgent or emergency attention, which may not be available in all places across India. And lastly, when you have to take summary or conclusions, you have to principle will be to maximize the benefits and minimize the harms. We have to consider these three key considerations: which agent will be more effective in that patient. Second, is cardiovascular protection or event reduction expected with SGLT2 inhibitor, and is there any tolerability related concern for these agents? I have already told you that both these agents are excellent agents. They have withstood the test of time. So when you are using these agents, kindly look into these considerations or these questions when you are treating your patients, and you will get the maximum benefit and minimal harmful effect from these agents. Thank you for a patient hearing.
Thank you very much, Patak sir. We have aptly told the audience about the pros and cons of using DPP4 as well as SGLT2 inhibitor. Are there any questions? We'll just allow 2-3 questions.
Okay.
I guess there is a question. So, Dr. Shivanand Nayak has asked, in renal impairment stage 3 onwards, only insulin to be used?
Not necessarily. Nayak sir, not necessarily insulin. You can use some agents. If the GFR is between 30 to 60, you can use SGLT2s, you can use DPP4 inhibitors, and some oral anti-diabetic agents like alpha glucosidase inhibitors or repaglinide-like molecules can be used safely along with insulin, but it is not mandatory that you have to use insulin. If your oral anti-diabetic agents like non-secretagogue sulfonylureas like repaglinide or alpha glucosidase inhibitors or smaller doses of these gliptins can control the blood glucose, you can use them also.
I think that was the only question. Thank you very much.
Thank you, sir. Thank you.
Thank you, Patak sir. Yeah.
Thank you.
Now we move on to the next speaker, and none other than Dr. Ian Pinto. I request Dr. Jitesh Mehta, our President-elect, to introduce Dr. Ian Pinto. Dr. Jitesh.
Hello. Yeah. Good morning, everybody. Yeah, Dr. Ian Pinto is a consultant at the Department of Medical Oncology at the Sir H.N. Reliance Foundation Hospital and Research Center. After passing his MBBS from Mumbai University, he was further trained and worked in USA for 15 years when he completed his MD in medicine, DM in hematology, DM in medical oncology, MPH, Masters in Public Health in New York. He has trained and worked at the top centers of the world such as Memorial Sloan Kettering Cancer Center, New York University, Columbia University, and State University of New York. He additionally gained training and experience in autologous, allogenic, and umbilical cord bone marrow stem cell transplantation at Memorial Sloan Kettering Cancer Center, State University of New York, and Tata Memorial Hospital. He has been awarded various scholarships, awards, and prizes in his career. He is a fellow of the American College of Physicians, New York. He is a member of the American Society of Blood and Marrow Transplantation, American Society of Clinical Oncology, and American Society of Hematology. He has presented and published many papers and studies in reputed journals. Today, Dr. Ian Pinto will be talking on a decade of eltrombopag in ITP, the only oral TPO RA. Dr. Ian Pinto, you're welcome. Please join and address the group.
Thank you, Dr. Mehta. Thank you, Dr. Mehta. Thank you, Haji Ali IMA and Novartis for having me here today. The last time I was there was in person in August 2018. I spoke about ITP, and we went through, for whoever was there, we went through the basics of ITP, what exactly it is, the clinical features, how we, treat it. And today, I think I'm going to focus more on an oral tablet, especially very important in our days because we try to avoid IV stuff now, especially with COVID, called eltrombopag. And it's a decade long of eltrombopag in ITP. So ITP care 20 years ago, we had a limited pathophysiology. We hardly knew much about it. We always thought 20 years ago that, the goal was to get the platelets to normal level. Okay. There were no drugs developed at that time, very low efficacy. Surgeons love to take out the spleen, and splenectomy was very big in those days. And we hardly tracked any epidemiological data on that. So in the 1800s, this is the typical work from home diet, moderate exercise, generous diet, and free use of wine for treatment of ITP. And then as we progress, in the 1900s, splenectomy came into fashion because, it was found to actually help ITP patients. As all of you all know, the 1950s saw a lot of steroids because they were the wonder drug until we figured out that they have tons of side effects and, long-term use was bad for us. And then gradually we have progressed to immune suppressants, IVIG, rituximab, and then we have the thrombopoietin receptor agonists and new targeted therapies. So in comparison to 20 years ago, we have more research and advances. Our care is more focused towards the person. It's individualized. We're looking at quality of life. And since I cross both the oncology and hematology, even in oncology now, all our outcomes in our trials are about quality of life. We've got better treatment pathways, more specific drugs that act actually on targeted receptors. We're collecting more data, and surgeries are definitely declining. Splenectomies are on the decline as we see. Now in ITP, why has our strategy changed? Okay, one, ITP. So a lot of people, if you notice with ITP, there's not much said about the fatigue of the patient in ITP, and I think that's a big problem that we have with a lot of patients in ITP. It's just fatigue of the patient. We're focused now on also bleeding assessment and trying to figure out what exactly is the pathophysiology in order to get newer therapeutic strategies. Just to give you the three main terminologies of ITP. So most of our patients as they come in are newly diagnosed in 0 to 3 months. As if it progresses beyond 3 months, we call it persistent ITP, all the way up to 12 months. And if you go beyond 12 months, then we're looking at something called as chronic ITP. Okay, and those are patients past 12 months. A lot of data has been accumulated now on quality of life in ITP, and there's a lot of focus on fatigue on the patient in ITP, because a lot of patients have fatigue with ITP. Um, one of the biggest, one of the biggest concerns of these patients are, when are they likely going to bleed? And a lot of anxiety about, oh, my platelets are really low. How can I fix this? Also, when the platelets start dropping down, the patient starts feeling very fatigued. However, physicians, when looked at a survey, physicians do not perceive patients have a lot of fatigue in comparison to patient perception. So patients feel much more, depending on their platelet counts, fatigue than actually we feel about it. Like I told you, anxiety about the platelet count stability, are we going to bleed? And, in COVID times, one of the biggest scares for all of our patients, and you as general practitioners know that patients don't want to go to a hospital. So the moment they feel uncomfortable with their platelets going really low, and you tell them that, oh my God, you need a platelet transfusion, you're going to bleed, there's a lot of anxiety, and that anxiety is worsened in COVID times rather than in non-COVID times. So very, very important, to understand the patient psyche in ITP. Now, we all know a lot of the first-line therapies because there's data on the first-line therapies. We use, ROGAM or anti-D, steroids, dexamethasone, IVIG. In the second line, there is data, but very retrospective, small group studies. So not typically, phase 3 studies as we have for the, third line agents, like TPO receptor or thrombopoietin receptor agonists. So more data on the subsequent lines, less data on the second line. We have a lot of treatment options, for ITP. On my talk at the last time, I did mention why dexamethasone, is probably a better option than simple visolone or prednisolone. And nowadays, we're trying to limit the exposure of the steroid to the patient. We use shorter bursts of dexamethasone versus longer treatment with visolone tapers. There is data on Helicobacter pylori eradication and that affecting, ITP patients. We do have thrombopoietin receptor mimetics, and we're going to talk about that. And of course, a lot of you all know about anti-CD20 molecules. CD20 is a receptor, on lymphocytes, and those are the ones that kind of go, and break down, platelets. So rituximab that acts on that really helps with ITP. This used to be the landscape in 1996 to 2003 when we used, initially steroids. If it was persistent, we focused on a splenectomy. And then if it went past 12 months, we tried cytotoxic agents, okay? But the landscape has completely changed. As you can see, rituximab and thrombopoietin receptor antagonists have come much earlier, in the schema of treatment for patients with ITP. No one wants a surgery, right? So no one wants a surgery. So definitely splenectomy has gone lower down. So the biggest change actually of what we see is rituximab and thrombopoietin receptor, agonists coming up front there rather than being later on in the treatment. So steroids have a great response rate, 50 to 90%. But, the sad part about it is you have a great response, but only 15% maintain that response long term. The problem with steroids is, one is it's very tough to give a patient the steroids. They bloat, they have acid reflux, they're immunosuppressed. Of course, in this, this time and age, we don't want to be immunosuppressed. And each time I re-challenge a steroid, again, the side effects start. So the side effects can sometimes outweigh the benefits if given over a prolonged period. And that's why, like I mentioned, dexamethasone in shorter bursts rather than visolone in a longer tapered medication really helps. And steroids, as we all know, definitely attacks the bone. Now, rituximab is a great drug. I love it. I use it all across, lymphomas. Very well tolerated drug. But at this moment, it still doesn't have an approval for ITP, even though it's widely used for ITP. The response rates are high, about 60 to 70%. But then long term, after a year, it keeps dropping lower and lower, and then 5-year response rates drop down to 21%. We know that whenever we give a monoclonal antibody like rituximab, there is a chance of an allergic reaction, and that can be a major allergic reaction. So yes, there are side effects or serious reactions that can occur from rituximab. And it's an IV medication. For the first dose, we definitely admit the patient because it has to be administered over a prolonged period of time. And in COVID times, no one wants to get admitted. So we're trying to keep the patients out of the hospital. So it's very tough to tell somebody that they need to come in to get admitted for rituximab. This is looking at the long-term effects, both in adults and children. And as you see, you have a great initial response, but that response keeps dropping down, as we reach 5 years with rituximab. So, this almost looks like a stock market crash here. Although our stock market is still booming, even though our economy is going to crash. But look at the splenectomy rates completely dropped. Have I used splenectomies for ITP? Yes, I have, but definitely sparingly. If most other agents fail, then a splenectomy, is still used, but this is completely dropped, especially since the last few years. Now, we do have some other oral agents, older second-line treatments, azathioprine, cyclosporin. A lot of people have increased their use of mycophenolate, but the rest of them the use seems to be declining. Now, after we figured out that there was a thrombopoietin receptor that we could target, a whole new era for targeted treatments for ITP came across. Okay, and now it's 10 years since eltrombopag, which is the only oral tablet form drug that actually targets, the thrombopoietin receptor. As you can see, straight acting on the thrombopoietin receptor, causing signal transduction and then increased platelets. So it's a very direct mechanism of action of the drug. How do we administer this drug? They recommend an initial starting dose of 50 milligrams a day, and then you adjust to a maximum of 75 milligrams. Once a day, one pill, once a day. That's all you need, for treating, ITP. So it's not a multi-dosing drug, and it comes in 25 and 50. Now, the one thing about this drug is you've got to keep it away from antacids and dairy products, so at least 2 hours or 4 hours, before and 4 hours after any of those products. So that's one of the only restrictions on the drug, to avoid certain products with it when it's administered. They recommend a 50 dose. And we all start sometimes at a little bit of a lower dose at 25. And then, because we have some data that the AUC and East Asian patients are much higher for this drug. And so a lot of Asian populations, we recommend starting a little bit lower at 25 also. So that might be a lower starting dose. But the mean daily dose, is still around 50 to reach a platelet count of, more than 30,000 for 25 weeks. So it's still 50 seems to be, where we kind of plateau at as a dose that actually causes the response that we want. Now, if you're starting at 25 and your platelet count is less than 50,000, and we watch for 2 weeks, because sometimes it takes 2 weeks to get the desired response, then we would increase the dose by 25 milligrams. So we make it 50 and then 75, which is the max. Okay. Some patients, we see an excellent response, and suddenly you're up there to more, 200 to 400,000, and then we've got to wait for 2 weeks, to reassess after we decrease the dose. So say we have started 50, we're seeing a really high jump, we decrease it to 25, wait for 2 weeks, reassess the dose. and then go according to that whether we want to increase or decrease, further. Some patients where we have more than 400,000, we just basically stop the drug and then reassess, twice a week to see where the platelet count leads us. And as long as it's, doing well, we can hold off. But once it's down to less than 150,000, we would slowly reinitiate the drug. Now, the one thing is with hepatic impairment, you want to start a little bit on the lower side of the dosing, about 25. So Revolade should be discontinued. I didn't make this point. If your platelet count does not increase up, above 50,000, even if you're on 75 milligrams of Revolade, for 4 weeks duration, and you're not reaching the cutoff, it should be discontinued. For these thrombopoietin receptor agonists, we've got several randomized large-scale studies, data sets. The side effect profile is well characterized, and efficacy has also been, delineated in phase 3 studies. What is the benefits of the TPO? And I think the number one benefit, especially in COVID times, is that there's no immunosuppression of this drug. We have rituximab, we know decreases the immune system for a long period of time, maybe even sometimes 3 to 6 months. And you don't want to be immunosuppressed on a steroid or rituximab during COVID times. This drug, no immunosuppression, efficacy is very high, 80 to 90%, well tolerated, and may even work in refractory patients. Now, this is a study of the RAISE study looking at platelet counts and bleeding. And you can see eltrombopag in the blue doing really well with platelet counts, and you see the same effect with not much bleeding once the platelets are elevated. And once you stop it, then of course everything goes haywire. Now, there is a rapid response with Revolade, and you see that in the first 2 weeks, okay? And almost 88% will show a response in the first 2 weeks, okay? So this was seen, in their pivotal trial with eltrombopag. This, I think, is one of the best things, that once you're on Revolade, you can get rid of the accessory medications. And when I say accessory medications, what I'm trying to say is the steroids. We don't want to have patients on chronic steroid use, especially in COVID times or at any times, because of the side effects and the immunosuppression. So this is one of the most important parts. Only put them on one drug, get rid of the immunosuppression, and patients do well. And, when you look at even bleeding risk, even long-term data, bleeding was, definitely reduced by almost half from the baseline. The thing with the eltrombopag is it's not just a short-acting medication. Responses that we see last all the way up to 8 to 9 years. So this drug works for a long period of time. And, they've looked at it from around 9 years of data sets and minimal side effects, maybe some mild headache, diarrhea, fatigue, but mostly really, really well tolerated medication. There are some immune stimulatory effects of the drug, and that can lead to sustained remissions, like increased Treg activity and Breg activity, a decrease in IL-2 and increased TGF-B. And so there are a certain group of patients, around 30%, that can actually taper and stop, TPO agents or thrombopoietin receptor antagonists. Okay. Now, I told you, even in hematology or oncology, we're all looking at quality of life of the patient, because that's the most important. And here you see across the board in the RAISE study that quality of life has been improved with eltrombopag. Sustained remissions are also seen with eltrombopag, and this is a retrospective study that looked at patients who actually stopped their medication after a complete response. That means normalizing of their platelet counts. And you see that of the 49 evaluable patients, 53% showed a sustained response even after discontinuing eltrombopag without any other therapy. In the whole group, it was at least around 33% had a sustained response. So maybe some sense of a sustained remission, with sometimes with chronic persistent ITP, is a very good thing to see. Now we do have another thrombopoietin receptor antagonist. It's called romiplastin, and the sad part is it's a subcutaneous injection, so you have to administer this as an injection. It's a weekly bolus injection, whereas when we compare it to an oral tablet, a tablet always rules over an injection. Romiplastin is initially dosed at 1 microgram per kg and then adjusted weekly by 1 microgram per kg up or down. And you have to store the romiplastin at 2 to 8 degrees. So that is also another thing. In order to administer the drug, it has to be stored appropriately versus Eltrombopag that doesn't have to do that. The thing with giving romiplastin, since it's a weekly dose, has a lot of fluctuation, of your platelet counts, and versus Eltrombopag, which is very smooth, platelet counts. And I told you this is COVID times. No one wants to go to a doc to get an injection, So, and the tablet, of course, is much easier than an injection. As you can see here, romiplastin with the platelet counts all over the board. Eltrombopag, a very stable, consistent platelet count maintained throughout. So I told you a lot of ITP is anxiety in the patient, that suddenly their platelet count has dropped. And when you have a fluctuating platelet count dropping and going up, it adds to the anxiety of the patient that they might bleed. So it's more important to have a stable platelet count. Now, can we move from one thrombopoietin receptor agonist to another? And there is data retrospectively looking at that. And they see that if you switch from N-plate to Eltrombopag, you still have a good response rate, almost in the 46%. And if you switch from Revolade to N-plate, also you have a good response rate, high response rate in the 80%. So you can make a switch between agents. Now, this is my last slide. So just to focus on the conclusions, of today, Eltrombopag has definitely made a big impact as an oral tablet, in chronic ITP. It's been tested for around 10 years almost, and unrevealed, no unexpected risks. Amongst all the modalities in ITP, that's a great response rate, one of the highest response rates at 88%, and it's even effective after failure of romiplastin, which is a subcutaneous, injection. Some patients, even when they're off therapy, almost 33% show sustained responses. There are some dietary restrictions, as I mentioned earlier, but I think the key to this drug is, one, it's a tablet. It's dosed once a day, not many times a day, so it's easier for patient compliance. And it does not cause immunosuppression. Like a steroid or rituximab, there's no immunosuppression, especially when you're looking at COVID times. We need a drug which does not cause any immunosuppression. Those are my details. I'm at Dr. Vishkani, St. Elizabeth's and Harkisondas, and my contact details in case anybody needs to contact or email. Thank you for your time, and I'll be open to any questions.
Thank you very much, sir, for a very excellent and a very easy presentation on Eltrombopag. Are there any questions? Because there are no questions in the...
Can I ask a question?
Yeah.
So I just wanted to know, you said that if a patient is on steroid and you start with the Revolade and then you taper the steroid. So does that increase or decrease the dose of Revolade when you're tapering the steroid or removing it?
So that's a great question. Thank you, Dr. Mehta, for your question. So I as I see a platelet count. So suppose I've reached I'm tapering off a steroid and I'm not seeing that much of a good platelet count. I would add Eltrombopag, and I've done it kind of recently where we've added Eltrombopag at a lower dose. And if you're still not getting the bang for the buck, then I would increase it to the 50 milligram dose. And in this patient, especially just last week, increase it to the 50 milligram dose. Once you've maintained your platelet count at that number, then I would slowly withdraw a very, very slow, lower dosing of the steroid and follow every week to just make sure that we've got the platelet count above 50,000 or in that area. and
Does
gradually
it
taper
happen
off.
that when you're reducing the steroid, you need to increase the Revolade dose?
Uh, yes, but now what I've looked at is I wouldn't decrease the steroid until I have my platelet count.
Okay.
So yeah, so until I have my platelet count at about 50,000, I wouldn't want to decrease a steroid till I have that count. Okay,
It's a gradual process.
gradual process, and each person and each patient is different, so you will get a hold of it. But
Yeah.
if you're withdrawing the steroid very very slowly, very very slowly, as the platelet count stabilizes, so
Thank you very much. Thank you.
thank you.
Thank you very much, Pinto sir. And we move on to the next speaker. We have Dr. Suresh Advani sir.
Hello.
It's always proud to introduce Dr. Suresh Advani sir. He has a very long biodata, but which I have made it, tried to make it a small one. Dr. Suresh Advani is a consultant with the Medical Oncology Departments at Sir H.N. Reliance Foundation Hospital and Research Center. He is a recipient of innumerable awards throughout his lifetime. To name a few, Padma Bhushan in the year 2012, Padma Shri in the year 2002, Dr. B.C. Roy National Award by MCI, Lifetime Achievement in the Oncology by Harvard Medical International, Dhanvantari Award, Gifted Teacher Award, and many more. After completing his MBBS and MD in General Medicine from Grand Medical College, he joined Tata Memorial Hospital. He then went to train himself at Royal Marsden Hospital in London and further trained in bone marrow transplantation, at Fred Hutchinson Cancer India. He has played an important role in PhD guide in applied biology. He has been involved with about 500 national and international publications. This is really a very short biodata of Dr. Suresh Advani. He is a great teacher. I request Dr. Advani to begin his presentation. Dr. Chirag just loads his presentation.
Sure, sir.
Good morning. I'm really very happy to be here, and I always enjoy interacting with all of you. We have been interacting for a long time now. So, what I'm going to do today in another 25 minutes or so is to give you that how a common disease, breast cancer today is a commonest disease. And all of you must be facing this time and again, because the first time the patient notices some lump in the breast, they go to the family physician. That's a normal natural tendency. And ultimately, we all know that all lump in the breast are not cancerous. They can be benign as well. And that's where I think your interaction with the patient, interpretation, and guidance become very important. So not only in terms of the diagnosis, but also in terms of further treatment, your guidance to the patient plays a very major role and has an impact on the patient perception to the treatment. I'm going to show you how this knowledge, which all of us have acquired over a period of time, is helping the patient. 40 years ago, for us, it was sufficient that we used to see a lump in the breast. We will do the FNSE, fine needle aspiration cytology. The pathologist will tell us that this is a duct carcinoma cells. He will say, very good, here is a carcinoma of the breast, and go ahead with the further treatment. However, over a period of time, as we study more and more and more, as we treat more and more patients, we did realize that the breast cancer cannot be a single disease, because case by case, different patients different tumors in the same patient, different timing of the tumors in the same patient, the behavior and outcome and response is different. What is the meaning of that? Obviously, it means that we are dealing with a heterogeneous disease. It's not a single disease. And realizing this, we now know that there are some breast cancer which are very slow growing. The patient comes and tells you, I have this lump for last 5 years and slowly growing. And there are others who says you small 1 centimeter lump and within a month it has become 5 centimeters. So look at it, that how biologically they are different. And nowadays we have realized this heterogeneity based on the scientific approach. We know that different breast cancers have a different molecular abnormalities. They have a different clinical behavior. They have a different histological behavior. And they have also, of course, are associated with a different prognosis. So once you realize that the breast cancer is not a single disease and it has got the multiple types of the subclassified behavior, it becomes very important and critical to characterize the accurately so that ultimately we can give the best of the treatment, what we call it personalized medicine. Before this era, what we used to do it very simple, that we used to say stage 1 this is a treatment, stage 2 this is a treatment, stage 3 this is a treatment, and stage 4. However, today it is not like stage alone. I want to know what is the pathology. I want to know what is the histochemistry, and also I want to know what is the difference at the molecular level. So you see today the pathologist involvement has become much more in the management of the breast cancer. A clinician without a good pathological report can never do a justice to his patient. So I think this is what has been realized today, that we have to really have an interaction, very gross interaction with the pathologist. And also, the pathologists, when they give the reports, previously they will just write that duct carcinoma. That was the end of it. No, today they cannot afford to give that report. Today they will tell us duct carcinoma, different types of the grade in that, and then they will also tell us is it estrogen receptor positive, is it progesterone receptor positive, is it HER2 receptor positive or not, and also what is the proliferation index, we call it Ki-67. So all these things have become an integral part of the pathological report. Pathological report, if it is not associated with all these areas of reporting, it becomes incomplete. So next slide is to just to show you, next slide please, that how there are different definite entities within the breast cancer. And this is what we call it subtype. Broadly, I'm going to tell you what are the different types of the breast cancer. One is we call it luminal type, in which the lumen of the gland is maintained. And that is a lumen. There are two types, luminal A and luminal B. I'll come to it little later, what is the difference. Then we have tumors which are HER2 overexpressed. HER2 is grossly positive in there. ERPR may be negative, may be positive, but HER2 is overexpressed. That is a separate disease by itself. Basal-like breast cancer type, which is a where estrogen receptor, progesterone receptors, and HER2 receptors all are absent. So we call it triple negative basal-like breast cancer. They are like a basic basal layer of the breast uh, cells. And lastly, we have also a mucinous type of the breast cancer, so-called low-grade breast cancer, or also known as the Claudin low breast cancer subtype. So you can see how the breast cancer can be variable. Now, when I get the report, for me to get all these things is very important.
Otherwise, I can't treat the patient because I know that if it is HER2 positive, it has got a very aggressive behavior. I remember 20 years ago, as soon as the report used to come that HER2 positive breast cancer, we used to feel that this patient is going to develop metastasis soon and can die early. However, today that has changed. Why it has changed? Because now we can block the HER2 receptor on the tumor cell surface by a monoclonal antibody. We call it Herceptin. So you see now we have one more sort of armamentorium in our hand. By blocking the HER2, we can block its aggressive behavior, and it response to the chemotherapy becomes much better in fact. And therefore today, with the use of all these HER2 blockers, we are able to get a very good result. Probably sometime I feel that the results are better in the luminal A and B type. Similarly, triple negative breast cancer is one of the very important recognized breast cancer. About 25% of the breast cancer are triple negative. And what do the triple negative today tells us? Tells us that the patient is going to have very aggressive behavior. It is not going to respond to any tablets, oral tablets. And also, the response to chemotherapy is the only thing that you can do. And that also response may not be as good. And therefore, the triple negative breast cancer is considered with a bad outcome. I think one more thing that has come up, that if you diagnose a patient with a lump in the breast and you had done the biopsy and the results comes estrogen receptor, progesterone receptors, and HER2 receptors negative, one thing we have realized that don't waste time. Don't try to experiment with the surgery and all. All these patients with triple negative, even if they are small tumors, they must need the neoadjuvant chemotherapy, which means that the first line of action should be chemotherapy. And why so? Because by the time the triple negative breast cancer is diagnosed, already few cells have metastasized. In other words, the triple negative breast cancer has a high potential to disseminate initially micrometastasis and later on macrometastasis. And that's why they need the urgent neoadjuvant chemotherapy. Next slide, please. So I think all these things have become very important. And here you can see that luminal A and B type is associated with the better prognosis, while triple negative is associated with the worse prognosis. And in between is the HER2. Of course, the HER2 has improved today much because of the Herceptin. Next slide. I think one more thing that all of us have realized that the tumor is not only heterogeneous, broad classification I told you, but within the one tumor there are also heterogeneity. This is what we call it. First is inter-tumor heterogeneity. That means the different individual, somebody may have HER2 positive, somebody may have luminal A type, somebody may have triple negative. So this is what we call it inter-tumor heterogeneity. But there is also the heterogeneity between the tumor and the metastasis. The tumor may be weakly ERPR positive, but the metastasis may be even HER2 positive. So you can see that how there's a heterogeneity within the same individual, but in the primary and the metastasis. Also, the intratumor heterogeneity is also recognized. And you can see in this figure that how few cells they are in the biopsy is done. And if you get the biopsy from one area, you may diagnose something different as compared to if you take it out the whole area, then you can have the mixture of two different types of the population of the cells. So I think this is a very important thing to recognize, and that's how our treatment is modified nowadays according to all this information. Next slide. I'll just now show you that what is luminal A. What I mean by luminal A. These are the breast cancer patients who have got a very high expression of estrogen receptor and progesterone receptors. Overexpression. They will be 100% positive with the estrogen receptors. And they have usually low proliferative index, so they multiply slowly. And because of the high level of estrogen receptor, they respond very well to the endocrine manipulation, which means you can block the receptors. Either you can block the receptors or inactivate them, and then the response will be wonderful. And also, they have got usually a favorable prognosis. So among all the breast cancer, luminal A has a favorable prognosis. Next, in contrast to this, we have a luminal B type, which is also ER/PR positive, but estrogen receptors and the PR, progesterone receptors are weakly positive. And sometimes they can also have a small expression of HER2 also. Now, what does it mean? That it is not completely single type, but it's a mixture of the cells, and therefore it has got the weakly weak response to the endocrine therapy. And these are the cells which have got a lot of genomic instability, and they usually harbor the P53 mutation. P53 mutation is associated again with the poor response. You can also see that they are less sensitive to the hormonal manipulation and also less sensitive to chemotherapy and have a very high risk of relapse. So one can see that between luminal A and luminal B, how there's a difference in terms of biological behavior. Next. Similarly, the third type, HER2 enriched breast cancer subtype, is characterized by the presence of the HER2 on the cell surface. And this we do it normally by immunohistochemistry. Sometimes it may not be clear by immunohistochemistry that whether the HER2 is positive or negative. Then we do what we call it fluorescent in situ hybridization. It's the so-called FISH technology. And with this FISH technology, it becomes very apparent whether the tumor is positive or negative. And here there's a low expression of luminal clusters, and it almost 30% of the breast cancer are HER2 positive. Normally, they have a poor prognosis. However, this last sentence has radically changed. Introduction of the Herceptin has shown us a landscape change in the behavior of the HER2 positive breast cancer. In fact, it has become one of the best prognosis. Next slide. Similarly, the basal-like, or what we call it, triple negative breast cancer has got the worst prognosis, and usually it is characterized by high frequency of a gene, we call it DNA repair gene mutation. So these tumors have the BRCA1 mutation, increasing genomic instability, high expression of the proliferative index, and high grade histopathology. Looking at all these things, becomes very clear that triple negative breast cancer, even today, remains the most dangerous type of the breast cancer. Thus, friends, what is really has come out of all this information? That biological behavior, the clinical behavior of different type of the breast cancer is not uniform, and therefore not only they require the different type of the treatment. I cannot give the same treatment to HER2 positive and luminal A type. The treatment has to be different. So recognition of this has become very important. Sometimes we see patients, they are in a hurry. They say, well, diagnosis is made already. Why don't you start the treatment? I say, no, I'll be giving you wrong treatment if I don't get all the information. And by waiting for 8 days and 10 days, we have nothing to lose because overall breast cancer is a slow growing, take years to become apparent in the body. Next slide. Now I'll show you some of the how we treat these patients. Of course, the last type is low grade type of the breast cancer, where all these receptors are, of course, negative, and it shows metaplastic and medullary differentiation. Relatively very slow growing, can go on for 5-10 years, but with a localized disease. They have a very little ability to disseminate. Next slide. So now we are looking at what is the impact of the treatment. Next slide, you will see the impact of the treatment has been tremendous. For hormone positive, ERPR positive patients, we have see what a progress we have done in last 40, 50 years. Originally, when I entered into the medical oncology practice, 1970s and 80s, we had only one treatment, tamoxifen, very famous. Even today, we use the same thing. But it is a selective estrogen receptor modulator. So it has got a weak activity. Over a period of time, you see how we had the introduction of aromatase inhibitor, which inhibit the production of the estrogen in the body, anastrozole, exemestane, and letrozole. And then came the selective estrogen receptor degrader. They degrade the estrogen receptors, and that is what we call it fulvestrant. And over a period of time, many combination also came. But one combination which has changed or brought about the revolution in these patients is the introduction of what we call it CDK4 and CDK6 inhibitors. And these are here like palbociclib, ribociclib, and abemaciclib. These are all the new drugs. They are given along with the aromatase inhibitor or along with the fulvestrant, and the response is tremendous. A patient who comes with a stage 4 disease with an extensive bone metastasis, and if he receives the combination of palbociclib along with the aromatase inhibitor, within a month or two, all the tumors all over the body, the activity disappears, and it can remain inactive for a long period of time, which may be 3 years, 4 years, 5 years. We have seen all these responses. So I think what we have really seen today in 2020, the total revolution. Next slide. I'll just show you some of the results. He says these are the early results where tamoxifen also helped the patient improvement in survival. Next slide. Then came the aromatase inhibitor, letrozole, that also improved the survival when it was given in an adjuvant situation. Next slide. And you can see that now we are using, along with the aromatase inhibitor, CDK4 and CDK6 inhibitors. Next slide. And look at it, what they have done. They have further improved the results tremendously. And I'm telling you, many patients, previously we used to give them the chemotherapy. Today we don't, because we have got such a good drug, new drugs, which can totally produce the response, very quick response. Also, the deep response. They really respond very well. Next slide. You can see also that how the uh, abemaciclib along with the fulvestrant is better than the placebo plus fulvestrant. The response rate is better. The survival is also better. Next slide. You can also see that same combination with the palbociclib also improves the survival. Next slide. So all these things do tell you that how over a period of time, introduction of the newer and newer molecules have improved the survival in hormone positive, HER2 negative patients. Now comes what happens in the HER2 positive patient. And you can see that lower graph was the survival when we were using only chemotherapy. We did not have the trastuzumab. Trastuzumab is nothing but the Herceptin. We did not have that. Therefore, look at it. Our survival was so poor. But now that we have got the trastuzumab, along with the chemotherapy, see the results. I mean, it's a dramatic difference between the survival with the use of Herceptin and without use of Herceptin. Next slide. So I think everything has really improved. There are many other monoclonal antibody apart from the Herceptin. One of them is Perjecta, pertuzumab, and you can see over here again that how pertuzumab with the docetaxel can improve the survival. Next slide. Not only that, we have the another molecule. We call it Kadcyla, where the Herceptin is conjugated with the toxin, call it 10-sen-mine. That's a toxin which normally, if you give to anybody, the patient will die. So what they have done is they have attached the Herceptin with this toxin in a very minute quantity. Such a minute quantity that it cannot do much harm to our normal cells. But when this minute quantity is targeted to the tumor with the help of the Herceptin, Herceptin targets HER2. So this toxin also goes to the HER2 cells, HER2 positive cells, and then it is internalized and the toxin is released inside the cell and the cells die. So this is what I think is the real development in the field of HER2 positive breast cancer, that we have a drug conjugate to give the results. Next slide. Same as with the pertuzumab. Next slide. Lastly, I must say that we are now in the era of immunotherapy. Next slide. I think particularly in the triple negative breast cancer, the immunotherapy has been shown a good results. So friends, my purpose of today's talk was to just tell you and inform you that breast cancer cannot be considered as a single disease. And it has to be, the treatment has to be personalized for individual patient. So we must do all the investigation to give the best of the treatment to these patients. Thank you very much.
Thank you very much, sir. There is one question from Dr. Namrata. Can a fibroadenoma and uterine fibroid become malignant? And what are the follow-up investigations for early pickup of any change?
Yeah, normally fibroadenoma of the uterus, they don't become malignant. So that's they remain as fibroadenoma for a long period of time.
Any other question from the panelist? Okay, no more questions.
Yeah.
So thank you very much
Thank
for
you.
an
Thank you very much.
excellent presentation, sir. And we move on to our next speaker. We have another luminary in the field of medical medicine, and that is Dr. Ashok Mahashur. I request Dr. Jitesh Mehta to introduce Dr. Ashok Mahashur.
Yeah, thank you, Dr. Anil. Friends, Dr. Ashok Mahashur is a very well-known figure. He really requires no introduction as Dr. Advani. Nevertheless, Dr. Ashok Mahashur is a senior chest consultant at PD Hinduja Hospital, Mumbai. He has done his MBBS from Nagpur University and MD in chest diseases and tuberculosis from the University of Mumbai. He has been awarded the fellowships from the Royal College of Physicians, Glaxo, the Indian College of Physicians, American College of Chest Physicians, and National College of Chest Physicians. He was awarded the Lupin Gold Medal oration by the Andhra Pradesh TB Association. He is a past president of the Indian Chest Society. He is a postgraduate teacher on respiratory medicine at the Mumbai University since 1989. With more than 120 scientific and research publications, including contributions to several medical books, Dr. Mahashur serves on the editorial boards for numerous biomedical journals, such as the Journal of the American Medical Association and the Indian Journal of Chest Diseases, in addition to being editor of Thorax India. He has received special training in fiber optic bronchoscopy, pulmonary function tests, and sleep medicine. Today, Dr. Mahashur will be talking on the diagnosis and treatment of pneumonia in COVID pandemic. Over to you, Dr. Mahashur. A warm welcome on behalf of IME.
Well, good morning, friends. It's indeed a pleasure to be talking to IMA doctors, though I'm coming here after a very long time. Now, the thing is, the topic I have been given actually is about the community-acquired pneumonia. Now, no doubt, COVID has revolutionized the management, but still, we cannot overlook community-acquired pneumonia. And my point, therefore, though it is a very important topic, I think it's very necessary that everyone is aware about how to approach a patient with community-acquired pneumonia. Because when we talk of this community-acquired pneumonia, I think when we talk of COVID also, it is the same thing that happens to be there. Can I have these slides a little readjusted? Just a minute.
So go on to the first slide.
Okay. Now, when we talk of the community-acquired pneumonia, I think we must know how the magnitude of the problem exists. In fact, the WHO has classified into community-acquired pneumonia and lower respiratory tract infections, and there are about 420 million episodes of illness worldwide. The mortality reported in India in patients with community-acquired pneumonia admitted to the intensive care is almost 25%. And around 20% of the mortality due to infectious diseases is caused by the lower respiratory tract infections. Now, studies from India reported variable rates between 3 to 11%. And in 50% of all patients, they are responsible for the pathogens which are not defined. So isolating a pathogen is extremely difficult. Therefore, the steps. So when we diagnose a case of pneumonia, I think first thing we should think, what could be the organism? Number two, where the patient should be treated, whether at home or in the hospital, and what the treatment should be. So best is I would start with a case illustration. This is a case of Ram, who is a 72-year-old man, lives with his son and family. Age is 72. He becomes unwell with feverish feeling, body ache, and a cough that has got worse with purulent sputum, shortness of breath, and pain in chest. Now, after experiencing these symptoms for over 2 days, his family suggests that he visits a doctor. And on examination of a family physician, he finds that there are inspiratory crackles or rales which are in the right lung base. 100 degrees Fahrenheit is his temperature, breathing rate 20 per minute, blood pressure of 135/87, and a pulse of 94 beats per minute. X-ray facility was available, X-ray was done, which confirmed the diagnosis of community-acquired pneumonia. Naturally, the questions in front of the family physicians would be, should the patient be hospitalized or treated in the community, how would you decide? So there are certain objective parameters, and these are very well defined by different societies. And this is called as either a severity of illness score or a curve, CURB 65 score. CURB means confusion, blood urea nitrogen, respiratory rate, blood pressure, and age. Now, any patient above 65 years of age with a low blood pressure, systolic less than 90 and diastolic less than 60, with a raised BUN and no mental confusion, would be each point gets 1 mark. And therefore, that's how we calculate the score where the patient should be. The limitation in this is when you see a patient in your clinic, you do not have BUN. So a modification in that is CRB score, that is without blood urea nitrogen. That's also extremely useful in community-acquired pneumonias. So if we look at Ram's condition, who is 72 years old, has fever, cough, they score 1 point of CRB 65 scale based on his age. Only his age being higher, it is giving him 1 point. The other criteria with reference Indian and IDSA has been minor and major. This, of course, requires little sophisticated investigation, so may not be practical in a community setup. Respiratory rate more than 30 breaths per minute, PaO2, FiO2 less than 250, multilobar infiltrates, confusion, uremia, which is raised, leukopenia, which is counts less than 4,000, thrombocytopenia, platelet less than 1 lakh, hypothermia, hypotension. These are the minor criteria. And the major ones are invasive mechanical ventilation need and a septic shock with the need for vasopressors. Now, any patient who has a presence of 1 major and 3 minor criteria should not be admitted as an outpatient. He should be hospitalized. So just to summarize, how would you decide? You get a patient of community-acquired pneumonia, you diagnose that possibly he has CAP. So the severity scoring system is CRB is either CRB 65 is more than 1 or SCRB 65 more than 2. The predicted rules 4 and 5, he needs home treatment. But if you find that there is a risk of rapid progression, poor oral intake, alcoholic, or concerned about the care in the home and oxygen saturation less than 90%, he should be admitted and observed on an indoor basis. And high-risk patients are the ones who are either in respiratory failure or have a septic shock, and they should straight go into intensive care. So I think your concern mainly revolves around the less severity index, OPD management of the patients. So the questions you ask, what are the most common etiologies of community-acquired pneumonia? Because you have to start the treatment empirically. And what antibiotics would you prescribe to these patients? Well, all over the world, even in Bombay, the studies have shown that whether the patient is ambulatory, hospitalized, or in the ICU, the commonest bug you must think of is Streptococcus pneumoniae. In an ambulatory patient, you can have Mycoplasma, Haemophilus influenzae, then Chlamydia pneumoniae, or respiratory viruses, which spatially are important in today's situation. And in hospitalized non-ICU patient, you have Chlamydia, Haemophilus, Legionella. then aspiration and respiratory viruses. Whereas in ICU, you must think of staph, Legionella, gram-negative bacilli, and Haemophilus influenzae. So how empirically the treatment is going to start on these patients? Well, no comorbidities or risk factor for MRSA or Pseudomonas, best antibiotic would be amoxicillin or doxycycline. Doxycycline has side effects, therefore less used, or a macrolide if local pneumococcal resistance is less than 25%. Macrolide is a useful antibiotic. But if the patient has comorbidities, yes, COPD, severe bronchiectasis, etc., then a combination therapy with amoxicillin clavulanate or a cephalosporin and a macrolide or a monotherapy with respiratory fluoroquinolones, which in our country, I would not mention it very strongly. So mainly combination of amoxicillin clavulanate and macrolides would be a better drug. The physician prescribes 5-day course of amoxicillin clavulanate at a dose of 1 gram BID empirically. He recommends taking analgesics such as paracetamol for his chest pain, advises him to take rest and plenty of fluids, and he was asked to follow up after 48 hours. He returns after 3 days. He's feeling better. His symptoms have started to improve. Physician tells Ram that his symptoms should steadily improve, but it may take a little time before he gets to normal. And therefore, the smoking advice to stop smoking and continue rest. So that's a typical outpatient case which could be managed with community-acquired pneumonia. Then you had Damini, who is 67 years old, has lived alone since her husband died, non-diabetic. She was usually seen working in the garden, but her neighbor had not seen Damini for a few days. So he wondered what's happened. Damini seemed unwell, confused, and the neighbor took her to visit to the physician. Now, what symptoms would indicate that pneumonia in this elderly patient? Well, the physician carried out an initial examination. On auscultation, there were crackles. Her blood pressure was 87 by 55. She was becoming increasingly confused, and Damini was referred to a nearby hospital for further evaluation and management. And as you can see her X-ray here, there is a patch which is seen in the left lower zone. So what investigations would you request? This patient is of a different category than the earlier one. More serious, more disturbance of vital parameters. So what investigations? The CRB 65 score was 3, indicating she is a high-risk patient. Based on clinical judgment, the decision was made to treat her in the hospital ward. Chest X-ray revealed left lower lobe consolidation and underwent full examination, blood count, urea and electrolytes, random blood sugar, liver functions, CRP, pulse oximetry, and pre-treatment blood samples. So these are the higher line of investigations. And what treatment was given to this patient who was hospitalized? Well, on the basis of severity assessment, she was given amoxicillin clavulanate, 1.2 grams TID IV. Diabetes was managed by insulin. General management included oxygen and hypoxia and fluid management. Closely monitored, gram stain revealed Streptococcus pneumoniae. Condition began to improve after 3 days, and she became well after about 4 days. So how do you manage different stages of community acquired? There are a host of guidelines. Different societies all over the world have given guidelines for this. And there's a good article on diagnosis and treatment of adults with community acquired pneumonia published by the American Thoracic Society. And that's a very useful, which gives the guidelines. Indian Society, Indian Chest Society and National College of Chest Physicians has also come out with their own guidelines. So what they say is that first you have to do a severity assessment before deciding on anything. And if there are unfortunate patients in a smaller place where no chest radiograph is available, then community acquired pneumonia could be defined as symptoms of acute lower respiratory tract infection, cough with or without expectoration, shortness of breath, pleuritic chest pain for less than 1 week, at least one systemic feature, either febrile patient, chills, rigors, and or severe malaise. New focal chest signs on examination. You get rales or bronchial breathing, and no other explanation for the illness. You should label the patient as community acquired pneumonia. When the chest radiograph is available, then there is no question. You do an X-ray chest in a patient who has lower respiratory tract infection symptoms and then decide for the course. So how do you optimize the diagnosis? Signs and symptoms. Chest X-ray, which is a cornerstone when you call it pneumonia. HRCT in patients where you suspect other diagnosis. CRP, this is not routinely done, prolactin and all that. Pulse oximetry, CBC, biochemistry like urea, electrolytes, blood sugar, LFT. Most important is sputum gram stain, blood cultures and sensitivity if the patient is severely ill. Pneumococcal PCR is also available, more sensitive. Legionella antigen in urine, molecular diagnostic test for atypical organisms because the percentage of atypical organisms is increasing. And in India, you cannot overlook tuberculosis. Therefore, all the efforts should be made to rule out diagnosis of tuberculosis. So how do you manage? Treat bacterial infection only. Optimize, maximize, recognize, utilize, integrate, prescribe, and encourage. All these are the integral part of managing a lower respiratory tract infection with community-acquired pneumonia. The empiric therapy is based on the most likely pathogen, knowledge of local susceptibility patterns, pharmacokinetics and dynamics of antibiotics, compliance, safety and cost of drugs, and recently administered drugs which you should omit. The Indian data show a good response to Streptococcus pneumoniae to commonly administered antibiotics. Duration of therapy, now there's a lot of confusion, but in OPD, 5 days is enough. Uncomplicated, in patients, 7 days is enough. Need to cover atypical organisms is extremely high these days, and you should make all the efforts to cover for that. Patients with comorbidities, amoxicillin, doxycycline, and macrolide. Patients with comorbidities, amoxicillin, and a cephalosporin, either cefuroxime or cefpodoxime, and a macrolide or a monotherapy with fluoroquinolone. Non-severe community-acquired pneumonia with no risk factors for MRSA or Pseudomonas, same thing, combination of beta-lactam and like cefuroxime, macrolide, either azithromycin or clarithromycin, or doxycycline, which is now coming up back in use but not very often used, or monotherapy with respiratory fluoroquinolones. Severe cap, beta-lactam plus a macrolide. Very important to have a macrolide to cover atypical, or a beta-lactam plus a respiratory fluoroquinolone. With MRSA, I think vancomycin or linezolid, and with Pseudomonas, piperacillin, tazobactam, cefepime, ceftazidime, aztreonam, meropenem. You have a wider choice in that, and newer antibiotics are coming up. So ICMR 2019 has recommended that outpatients without comorbidity, coamaxiclav, alternative macrolides, cefuroxime, cefuroxime. Beta-lactams are preferred over macrolides due to high prevalence of macrolide resistance, which unfortunately does not apply in India. Outpatients with comorbidities or use of antimicrobial in 3 months, coamaxiclav and macrolide odoxy, or the cephalosporins and macrolide. This should be the combination. In India, the resistance pattern of pneumococcal resistance revealed very low prevalence of resistance to penicillin in non-meningeal isolate. And so therefore, you can use penicillin very well. Now, I will not go into the details of the SOAR, that is the survey of antimicrobial resistance, but whatever you see green is the best sensitive, red least sensitive, and orange in between. So this is about different antibiotics, which may not be possible to go due to lack of time. But as you can see, most of these are being covered. One caution, FDA has advised that quinolones should be used with caution because of side effects and cover for tuberculosis. How do you prevent community-acquired pneumonia? Well, these are the vaccination, and I find a lot of confusion. This is my last slide. But I find a lot of confusion amongst the practitioners what to give. Well, there are 2 types of pneumococcal vaccine: pneumococcal polysaccharide vaccine and pneumococcal conjugated vaccine. The bacterial component and polysaccharide of the capsular antigen. So recommended all persons above 65 with patients high risk response between 2 and 64 years and or current smokers, pneumococcal polysaccharide vaccine should be given. All persons above 65 years or children less than 2 years or persons 2 to 64 years of certain medical conditions, pneumococcal conjugate vaccine should be given. The vaccine should be repeated after 5 years to have a long-lasting immunity. So thank you very much, friends. This is about the community-acquired pneumonia. As I said, though we have a COVID pneumonia, which is rampant, we should not forget community-acquired pneumonia, because what we are seeing now is there is a lot of association between the virus and the bacteria. And quite often, the COVID infections can lead to secondary infections, which need to be treated. Otherwise, they could prove fatal to the patient. Thank you very much for your attention. I think I'm open for questions if there are any.
Thank you very much, Marshall sir. We have one question from Dr. Nirmal Jain. How do we handle viral pneumonia?
Well, as I said, virals usually are atypical pneumonias. It's very difficult to isolate a virus. Therefore, a cover of atypical usually takes care of viruses. And azithromycin has been shown to have some antiviral property, which would have an adequate cover against a viral pneumonia. The management of COVID pneumonia due to COVID virus is an entirely different thing, which I was not told to cover today. I was only supposed to cover community-acquired pneumonia.
Sir, we have got a little more time. So can you just, in a short, tell us about the management of COVID pneumonia?
Well, COVID pneumonia is a direct extension of COVID infection of the upper respiratory tract, which commonly starts as fever, dry cough, runny nose, and the other constitutional symptoms. If you do not take care of the virus, it fixes into the ACE receptors and also lymphocytes penetration, which travel down and leads to pneumonia. The classic findings of a pneumonia in COVID are a person feeling breathless on exertion, drop in the oxygen saturation. So any patient who develops a breathlessness and drop in oxygen saturation, you should warn him to watch for the severe form of pneumonia. There's a very typical pattern of CT scan, and more than X-ray, I would rely on CT scan more to diagnose COVID pneumonia, which shows typical patchy ground glass basal and posterior opacities. They usually clear up with antivirals, but a large number can go into fibrosis. And the formation of fibrosis like interstitial lung disease depends on the age of the patient, severity of pneumonia, and therefore one has to be very careful and cover for the prevention of fibrosis. The moment the patient you diagnose to have a COVID pneumonia, I think best is to start him on antiviral treatment. Otherwise, it's bound to extend. And the best way to give antiviral along with a physiotherapy so that the secretions, especially in the elderly patient, do not descend down and cause confusion. Now, if you diagnose a mild case, ivermectin is a good drug, or Fabiflu also is a good drug which prevents the multiplication of virus. But the viral is one thing. What happens is the IL-6, which leads to the cytokine storm, and that leads to adult respiratory distress syndrome, where antivirals don't work. What works is steroids, maintenance of oxygenation, maintenance of fluid balance, etc. So what our job is to suspect COVID infection early, try to treat it early so that it doesn't penetrate into the lung and leads to pneumonia. Once pneumonia occurs, the prognosis is guarded. That's it. I think this in itself would need a special lecture, and if IMA invites me, I would be very happy to deliver it.
Yes, sir.
Thank you very much, Dr. Howard.
Thank you very much, sir.
Dr. Mehta.
Yeah. Friends, it was indeed a very good lecture by Mashur sir. We now move on to the next speaker, and that is Dr. Paresh Ved. Sir, can you
Put up. Just.
Mashur sir, I think you should stop screen sharing. Yeah, we have got Dr. Paresh Ved, the next speaker. He is a founder and consultant diabetologist at Wellness Diabetes Speciality Clinic. He is also a consultant diabetologist at Kohinoor Hospital and Hindu Sabha Hospital. He is a lecturer at KG Somaiya Medical College, Science. He is a postgraduate teacher at College of Physicians and Surgeons. He has got many research papers in medical journals to his credit. Dr. Paresh Ved will be talking on a very altogether different topics, and that is smooth sailing versus rough patches. Over to Dr. Paresh Ved.
Thank you so much, Dr. Anil. Can I share my screen now?
Yes, sir. Yes, sir.
Yeah. So this is good, Dr. Anil?
Yes, yes, sir. Yeah.
Wonderful. So I'm going to start. No, actually, Dr. Pathak has spoken so well about gliptins in clinical practice that he's made my work very easy as well as very difficult. So what I'm going to slightly do is talk about what I do in my practice so that it may help all of you in taking treatment decisions when you are treating your patients. What is the smooth journey all about? Smooth journey means you have to achieve and maintain a very good glycemic control and to avoid complications and to avoid treatment related hazards, right? Everybody here talks about guidelines. Okay, let me tell you, the first thing on the guidelines is everybody, yeah. I think everybody should mute their mics so that they can hear me clearly. Yeah. So the most important thing about guidelines is that the guidelines are supposed to guide you into a particular treatment. Why am I saying this is we directly speak about the drugs, but don't you think that all of us should be speaking more about lifestyle modifications? Now that has become a bit easier because we have got very good sensors available. Initially, which we had sensors, the CGM has to be put here and the patient visits the doctor after 7-8 days and then the doctor analyzes the data. Now we have got real-time sensors, so we can put a sensor on a patient. The patient can see the sugars himself and take an informed decision regarding the food habits that it is making. So I think the first line in the ADA guidelines, lifestyle modification, should be written in more bold than what the pharma people generally want us to read. That is the first thing I wanted to tell all of you. So the second thing I wanted to tell you is that the guidelines which actually are supposed to guide us are sometimes destined to fail, because the first thing that they tell us is that you do lifestyle modification. If you advise a lifestyle modification to a patient and tell him to come after 2 weeks, there is very much a likelihood of him actually coming to you after 4 weeks or after 2 months altogether with a much higher sugar. And then when you start metformin and then again tell him to come after 1 month, he is going to again take say 3 months and then again come with much higher sugars due to say poor compliance or poor eating habits. So what happens in such situation, I think many of you doctors will identify with what I'm trying to say, is that the right option for us is to treat to target. I think that is a more smarter thing to do. Dr. Pathak has told us so much about gliptins, so I'm going to tell you little about, actually gliptins are supposed to be safe, but there are some precautions which you need to take even while prescribing gliptins. I think I will allude to little on that also. Yeah. So all the medicines, all the drugs which we currently can give to our patients, the first one is metformin, the second one is pioglitazone, the third one which we used for a very long time was sulfonylurea, the fourth one was DPP-4 inhibitors, the fifth one is SGLT2 inhibitors. One more class of medicines which I have, drugs which I have not written here, but I think they work very well in Indian patient is alpha glucosidase inhibitors. I think patients with a very high carbohydrate meal, voglibose works very well. I've tried it in many patients, but this is an ADA statement, so I have not included voglibose. The Caucasians' eating habits and our Southeast Asian eating habits are very much different, so perhaps they have not included alpha glucosidase inhibitors here. But the basic idea is that there is no ready-made treatment. There is not a ready-made shirt which will fit all diabetic patients. So today I'm going to talk about a particular class of patients, considering the patient's age, the patient's eGFR values, and the patient's HbA1c values. So when out of these molecules, out of these drugs which are available currently, so if we look into these three factors, age of the patient, the EGFR of the patient, and the HbA1c of the patient, and then take an informed decision so as to get a better outcome, as well as to minimize the cost burden, then what actually should we do? I think I'm going to talk a little on the practical aspect. Some of the slides, I think Dr. Pathak has shown already, so I will try to sort of take them ahead a bit more faster. Yeah. So when we started speaking about diabetes, initially it was very simple. We just spoke about insulin resistance and we talked about insulin deficiency. Then later on, we had something called as a triumvirate approach. Then we had something called as omnious octet. I'm sure all of you must have heard that numerous times. I'm not going to allude too much on that. And then came something called as the dirty dozen. What matters to us the most, I'm going to tell you today in very, very short. The first important pathophysiology which we need to take care is insulin resistance. And I'm going to tell you all the molecules, all the drugs that we spoke about, which sort of work to sort of decrease these pathophysiologies which are involved in type 2 diabetes. The second one is in relative insulin deficiency. We know from our pathology that there is something called as apoptosis. So all these beta cells are programmed to die, have an early death. So we have to somehow find a way to prevent this apoptosis. Third one is a relentless production of glucose by the liver. That is the third problem. Hepatic glucose output is relentless. There is not much we were able to do about it before the gliptins came in. Then there is something called as an unchecked glucagon. Glucagon levels are very high due to alpha cell defect, and we need to address that also to sort of have a good HbA1c for our patients with type 2 diabetes. There is also something called as incretin defect, which I will speak to you in detail. This is somehow more specific to Asian subjects. I think I will touch on, Dr. Pathak has told you little about that, but I'm going to allude a bit more about that also. And the last part, SGLT2 come into the picture, is the increase in glucose reabsorption due to upregulation of SGLT2 receptors. So this is the basic pathophysiology which we need to sort of conquer to have a better control of type 2 diabetes. So what exactly happens when a person is diagnosed with diabetes? This is when the diagnosis of diabetes is made. Three very important things happen. The first thing that happens is that the beta cells die out faster. Something called as apoptosis. I think we discussed that. And that definitely will lead to reduction in insulin secretion. Second important thing that happens is that there is a relentless hepatic glucose production. And there is an insulin resistance which is almost like a plateau. We cannot do much about this. And if we are able to address these three basic pathologies of type 2 diabetes, then we definitely have a very good result in getting a good HbA1c control. So of course, there will be a great value if we can address insulin resistance, insulin secretion, and hepatic glucose production. So we have to look for a combination of molecules which are able to do this in a gainful way. So again, coming to the treatment options which I discussed to you, and the pathophysiology which I discussed with you, insulin resistance can be taken care of by using pioglitazone, by using metformin. DPP4 also contributes. Relative insulin deficiency, DPP4 inhibitors work very well. They inhibit the DPP4 enzymes, and definitely the insulin levels will be higher. Increased glucose output from the liver, of course, here also DPP4 inhibitor play a very important role. Alpha cell defect, again metformin, DPP4 inhibitors have a very good role to play. And glucose reabsorption, as we know, SGLT2 inhibitors work. Incretin effect, of course, it is the main main reason how DPP-4 inhibitors work. So incretin defect DPP-4 inhibitors work very well. Metformin also contributes in a little bit in this pathophysiology. So coming back to challenges that we face in our daily practice. The first challenge we face is that we are not able to monitor the patient and ask him to sort of comply with the investigations which we really want him to come and the follow-up. So we need a molecule which is more durable, so that like suppose if I'm doing an online consultation or I'm doing a video call consultation, then I should look at which molecule will I be more comfortable in using, comparing their risk profiles. Okay. At this point, it will be very wrong to say that gliptins do not have any side effects. Of course, I'll be telling you that in a bit also. The first challenge that we face is that some drugs get less effective as age advances. The second challenge we have is that some OADs, they work better at higher HbA1c level, and as the HbA1c level comes down, their efficacy considerably reduces. The third challenge that we face is renal function. I think Dr. Pathak has alluded that very well, that as the eGFR decreases, SGLT2 inhibitors don't work as efficiently. In fact, after 45 eGFR, I would be cautious in using SGLT2 inhibitors, and of course they are contraindicated to use if the eGFR is less than 30 ml per minute per 1.73 meters square, right? Also, there is something like a class effect, maybe, that some OADs work better in Asians than in other class. I think I will tell you that in detail. I've got one small slide to tell you about that. Beta cell function, as we all know, beta cell function is gradually going to go down. So when we used dionyl in those old days, somehow we saw that dionyl suddenly stops working. So we first called it primary sulfonylurea failure. So we said that no, we need to change the sulfonylurea. Then we realized that it is not a sulfonylurea failure, something called a secondary sulfonylurea failure. But actually what happens is that there are not enough beta cells to work on. Actually, the first time the diagnosis of diabetes is made, 50% of beta cells have already gone. That is when the patient manifests at diabetes. So after a few years of diabetes, we do not have too many beta cells to work upon. So that is why sulfonylureas stop working after some years. Yeah. So now I'm just talking about an OPD practice because that is where I practice most. My main focus of practice is clinical practice rather than IPD patients. So what do you generally do? Like if you have a patient who's on metformin or is on metformin and sulfonylurea, what is the commonest time when you would like to introduce a third agent? And what is the class of the patient that you will more commonly see in your clinical practice? Of course, for all our patients, I think all of you know that we would like to keep our HbA1c at 7. Only in some cases, we would like to go up to 7.5. So if I talk about my clinical practice, I think most of my patients here will fall between the age of 8, between the HbA1c of around 8.5 or lower. We also have, like if I can just tell you the ratio very roughly, it could be around 70 to 30% of more than 8.5. So is this too bad, having an HbA1c high? Let me tell you one very good thing. Okay, that NIHANS is, if you see the NIHANS data, 48% of patients with type 2 diabetes were not of target, out of which 56% were in 7 to 8% range. What it means is that even when medicines, the cost of drugs is borne by the government or by the healthcare system, there are a large group of patients in which an HbA1c is not addressed. if you see the 2010 to 2014 data, again 47% were in the 7 to 8% range and 49% were not in target range. If you see the data from Canada, 86% of type 2 diabetes patient has an HbA1c of less than 8.6. So of course, there is a need of better control of diabetes in such patients. So should we start metformin and then add on, or then we should directly go for say 2 drugs, 3 drugs? Actually, this entire debate, okay, it started about 15 years back when I was a student under Dr. Vijay Panikar and Dr. Shashank Joshi. And in the ADA, we had presented a paper on triple drug combination on patients with type 2 diabetes, which included patients already taking OHAs and also included drug naive patients. And that time, to tell you the truth, we were really ridiculed by some of the foreign counterparts, saying that no, it is too early and this is way out of what we have all talking about the guidelines. But now I think people are talking more and more about combination, and I think India is the combination capital of starting anti-diabetic therapy. So now I can proudly say that most of my patients, I would not like to start only on a metformin. I would like to start a combination therapy from them, depending on the age of the patient, the EGFR of the patient, and as I said earlier, HbA1c of the patient, also looking into account the cost burden which the patient will incur due to this combination therapy. The next question for all of us: what is the EGFR of an average type 2 diabetes patient, and what percentage of type 2 diabetes patients have CKD, or you can broadly say have an EGFR of less than 60? The results which I'm going to show you will perhaps shock all of us. 1 out of 2 patients in India will also have a CKD. And again, this is a NIANS data saying that an average EGFR of a diabetic patient is 81.6 ml per minute per 1.73 meters square. So, and as you know, EGFR drops. EGFR drops by about 3 to 4 ml per minute every year. So this is a ongoing concern for all our patients with type 2 diabetes. So what do we do now? What do you mean by smooth sailing? Smooth sailing means whenever we talk about a drug, it should have a glycemic lowering across the duration of diabetes. That means in a newly diagnosed diabetes as well as a patient with long-standing diabetes, that is what I will call as a smooth sailing. It should be effective in various degrees of glycemia. It should work for high HbA1c levels. It should also not stop working when the HbA1c levels are low. So that is again what I will sort of qualify as a smooth sailing. And third is whether it is a durable option. That means it should not worsen the pathophysiologies of type 2 diabetes. It should have an acceptable side effect profile, and it should not have a continuous titration requirement, lower or higher. So this is what I would look in a smooth sailing for a diabetic patient. Coming on the next slide, of course, it should also take care of the comorbidities. So now again, the drugs that I spoke to you about, again, let us talk about all these drugs on this data which I told you, that is what I need for a smooth sailing for my diabetes patients. Metformin, we know it is very, very safe. We are very commonly using it. We have some reasons, some indications in which metformin is also used for patients not with type 2 diabetes, but other indications. So it is effective against all HbA1c baselines. It is effective in both early and long-standing diabetes. Of course, it will come first on my list. Pioglitazone again is one of my favorite. It works under all HbA1c baselines, and it is effective both in early and in long-standing type 2 diabetes. I think pioglitazone, because we are all Dr. Panikar student, I think we have all imbibed in us to use a lot of pioglitazone in spite of certain, objection from certain quarters. But I also tend to use pioglitazone a lot more. unless it is actually, I use pioglitazone for all my patients unless it is contraindicated for use. About sulfonylureas, yes, sulfonylureas will work across all HbA1c baselines, but as you know, after some time they stop working. As I told you, that they will stop working after a few years. So that is a bit of a yellow there amongst all the green. Gliptins. Gliptins have effective against all HbA1c, and they are a very durable class of drugs. Okay, some years ago, say a couple of years ago, there was a little concern about use of gliptins in patients with heart failure. Actually, this is not a new concern. Let me tell you, the first gliptin to come in the market was vildagliptin. Vildagliptin somehow never made it to the US. It never made it to the US because they asked for additional CV data, which the company did not bother to give, I think, for a long time. Now they have something called as a VIVID trial, which is not a CVOT, but nonetheless, it is a trial. Then sitagliptin came in. That was the second DPP-4 inhibitor to come. And I think that it got very good data. There was SEVER-TIMI data for sexagliptin, which raised some flag for use in heart failure. There was also an examined data for allogliptin, which of course is not very much commercially available here. There was a TECOS trial for sitagliptin, which is a very good trial. It definitely convinces us that we can use gliptins even in patients with heart failure, with reduced ejection fraction. We can safely use sitagliptin. And of course, there is a Carmelina trial for linagliptin, which also says that yes, you can use gliptins in patients with heart failure. What about SGLT2 inhibitors? Somehow all battles in diabetes now happen to be a battle between a DPP-4 inhibitor and a SGLT2 inhibitor. I'm not going to go there too much because I think both have their own places. I've been using both together also on several occasions. So I'm not going to bash them today and then praise them again tomorrow in the next lecture if I'm going to speak on SGLT2 inhibitors. I'm just going to help you make an informed decision depending on that particular patient. Like it is a tailor-made choice for that particular patient, but the one we are talking about, considering the patient's age, the patient's EGFR, and the HbA1c level. So if you just see how good or how bad is a sitagliptin. So if you see sitagliptin patients, which was tried on patients who are more than 65 years of age, the mean age in this trial was 72 years. And if you can see that if you compare it with the placebo, you are seeing that the HbA1c reduction with the sitagliptin is 0.7, and they had a baseline HbA1c of 7.8. So I think sitagliptin as monotherapy in elderly patients with a mean age of 72 years is working very well. That is the take home from this little slide. Also, if you divide this further, because I told you the mean age was 72, there were actually patients who were less than 75 years and more than 75 years. Somehow sitagliptin was same in both these class of patients, whether they were less than 75 or more than 75. It was as good or as bad in both this subset. So then I found out a data for an SGLT2 inhibitor, which fortunately or unfortunately happens to be Cana, which is a very similar data. Of course, the age group is slightly lower, but this is the best I could find. So here they chose patients between 55 and 80 years. The mean age here was 63 years. The mean HbA1c was similar, 7.7 years. And here you can see that in patients with patients with HbA1c, in patients with uh, age less than 65 years, the mean reduction with Cana was 0.82, but over the age of 65, the reduction is only 0.5. This trial used both Cana 100 as well as Cana 300 milligrams. We are not using 300, so I think this figure should be taken with a bit of a salt or spice or whatever. So that definitely means that with elderly patients, I'm more likely to use a DPP-4 inhibitor than using an SGLT2 inhibitor. Second, all of us know this. I think I told you about this. I'm not going to repeat. I think Dr. Pathak has also told you, as the duration of diabetes increases, EGFR is going to decrease. This is again a very, very good slide because it tells you the difference in two trials. Actually, what we have done is we have compared two trials. One was by DeFronzo and another was by Rosenstock. And both these trials were landmark trials. And when they are dissected into two parts, like patients with a baseline HbA1c of less than 8.5 and an HbA1c of more than 8.5, what we can very clearly see over here from both these trials is both this data is that in patients with HbA1c more than 8.5, it favors an SGLT2 inhibitor, whereas in patients with HbA1c less than 8.5, it favors more of DPP4 inhibitor. So as I told you, if the patient's HbA1c is less than 8.5, then I would be more likely starting a DPP4 inhibitor rather than an SGLT2 inhibitor for that particular patient. Now, there is a direct comparison between EMPA 10 milligram, EMPA 25 milligram, and sitagliptin in 100 milligram. Again, the same thing which I am trying to tell you. With an HbA1c of more than 8.5, the reduction with EMPA 10 is very good. EMPA 25 is also good. Sita will slightly fall behind, but if you see at HbA1c of less than 8.5, EMPA does about 0.5. Sita does slightly better in terms of 0.61. So I would definitely be more likely to write sitagliptin in this particular class of patients. Yeah, I think Dr. Pathak has told you this slide already that EMPA or any SGLT2 inhibitors, this is a class effect that as the EGFR decreases, SGLT2 inhibitors are not able to work so efficiently. In fact, I'm not using them for less than 45. The guidelines, they say that if you are already using them below 45, you can go up to 30. But as you can see, that somehow it is very closer to placebo, doesn't give me confidence in writing. Plus, they have a fair amount of side effect profile. So they can cause diabetic ketoacidosis, they can cause UTI, cause acute kidney injuries. So definitely I would not be comfortable using an SGLT2 inhibitors in these class of patients. Since we are speaking about side effects, I think we should also give a fair share of speaking about gliptins also. Remember, gliptins should never be used for type 1 diabetes. They are intended for type 2 diabetes. They are not used for patients who are less than 18 years old. They should not be used in patients who have got metabolic acidosis. In all patients, if you are using gliptins, make sure that you do a EGFR, because most of the gliptins will require a dose titration once the EGFR falls. So you have to be mindful of that. We do not know if gliptins get excreted or secreted in the breast milk. So of course, in such cases also, we should be careful. I would not be using a gliptin in pregnancy. Also, if the patient is to undergo any radiological investigation which will include an iodinated agent to be given intravenously, I would not be using gliptins in such a patient. So these are the few places where I would not like to use gliptins. These are the few rules which I would follow. Also remember that when gliptins came into it, there was some concern about pancreatitis. Then we said that no, the side effect profile is almost zero. That is correct. The side effect will be seen in only about 1% of patients. But you remember that as we are using gliptins more and more, we are seeing a few cases of GI disturbances. Of course, pancreatitis is a concern. I would not be comfortable using it. Patients which have got elevated enzyme levels, I would not be comfortable using gliptins at all. Also, they have got some allergic and hypersensitive reaction. Please, if a patient complains of allergic and hypersensitivity reactions after starting gliptin, do not sort of continue it, saying that nahi, ye nikal jayega, this could be due to diabetes, then it can actually become very bad. We have seen many patients. So gliptins also have their fair share of side effects, which after so many years we have realized. So that is, I think I went slightly away from the topic. I just wanted to discuss, be fair on both sides. Yeah. So when you compare now a gliptin with sulfonylurea, if you can see here in patients with CKD1, what happens is sulfonylurea will work slightly better. Sitagliptin will work slightly better in patients with CKD when compared with the sulfonylurea. When you see patients with moderate to severe renal impairment, you will see sitagliptin will be able to reduce an HbA1c by 0.8. Sulfonylurea will do that by 0.6. If you see patients with end-stage renal disease, I think sulfonylurea will reduce by HbA1c by 0.8, whereas a gliptin will do that by 0.72. But in this class of patients, and also in these class of patients, hypoglycemia is a real concern. So I would be very, very mindful of using a sulfonylurea in this class of patients. The sitagliptin in this case happens to have a much better safety profile compared to a sulfonylurea, and with almost comparable reduction in HbA1c. Yeah. Now a direct comparison between both of them, between sitagliptin and DEPA. So if you see here, sitagliptin was used in 100 milligram, DEPA was used in 5 to 10, but in most cases it was used at 10. The mean eGFR of the patients was 79 and 79 for sitagliptin and 76.9 for DEPA. And if you can see, the target that is reached by patient is sitagliptin, 42.6% patients were able to reach an target of less than 7, DEPA 27%, and almost as I told you, most of the patients received full dose of DEPA. So again, I want to tell you that in patients with decreased eGFR, using a gliptin is a better idea than using a DEPA SGLT2 inhibitor. This is again the same point which I wanted to put across. I think we are ending the end of my presentation. I will take questions if at all anybody of you wants to ask. So somehow DPP4 inhibitors are able to work better in Asian patients. If you can see this data, if you can see this, HbA1c reductions in non-Asian dominant studies, the reduction in HbA1c is 0.65. Whereas if you see Asian dominated studies, the reduction in HbA1c is 0.92. So because of because of the DPP4 upregulation, and because of I think also the type of carbohydrate that we intake, also there must be something related to race which we don't know. I think we will need further analysis and data, but this is a very interesting thing, saying that somehow DPP4 inhibitors are working better in Asian counterparts as compared to their Caucasian counterparts. So I think we have come to my take-home messages. Metformin is the perfect base. I use it the first. I think all of you do. Then generally, gliptins are generally safe. As I told you, there are some concerns, some things which you should not use gliptins. There's also a little side effect profile, but in less than 1%. So they are effective against all age groups, all HbA1cs, diabetes duration. Sulfonylureas, very effective in the beginning, but later on they don't work. Pioglitazone again are very effective, very durable, but I'm not able to use them in a few patients because we will not be able to talk about that now. SGLT2 inhibitors, they are very, very good. We have been using them for some time, but in patients with eGFR, with a compromised eGFR, and with patients with an HbA1c of less than 8.5, especially in elderly patient, I'll be slightly more mindful of using an SGLT2 inhibitors, considering the side effect profile. And of course, the best decision is made by us, depending on all the parameters. As I told you, I would take age of the patient, EGFR, HbA1c, and the cost incurred for therapy before starting a drug for a patient with type 2 diabetes. I think that is all I want to talk about. Thank you very much, and thereby we can avoid the rough patches.
Thank you very much, Dr. Paresh. I'm sure those who have attended your lecture will have a really have a smooth sailing while treating type 2 diabetes mellitus. Just take one question. What is the protocol for managing gestational diabetes?
So, see, what happens is gestational diabetes, the guidelines say that they have to be treated only with insulin. Okay, so gestational diabetes is something that comes after 28 weeks of gestation. Anything that comes before 28 weeks is actually type 2 diabetes, which is manifesting in pregnancy. So if it is more than 28 weeks, the guidelines say that you should use only insulin, but we are increasingly using metformin with very good results. In some patients, I'm not using metformin, not using insulin at all. I'm able to control them with metformin alone. You can also use glibenclamide. There is very good data available, but of course, it is still a bit early to say whether you can use glibenclamide, because glibenclamide does not cross the placental barrier. But insulin is the mainstay for treating gestational diabetes is the right answer.
Any question from the panelists?
Any role of oral medication in type 1 diabetes?
Sir, I am not using, to tell you the truth. If you are attending some lectures, some people might tell you that they are using SGLT2 inhibitors. And as I told you, I'm not using even type 2 diabetes less than 18 years. I'm not using the DPP4 inhibitors also. I'm slightly a cautious person, so.
Better to be cautious.
Thank you very much, Dr. Paresh. We come to an end of your talk.
Thank you, sir.
Yeah, thank you. And now we move on to the last lecture for today's CME, that is by Dr. Vaibhav Bagaria. And I request our President-elect, Dr. Jitesh Mehta, to introduce Dr. Vaibhav.
Thank you, Dr. Anil. Friend, this last speaker is not the least. Dr. Vaibhav Bagaria is a consultant in the Department of Orthopedics at the Sir H.N. Reliance Foundation Hospital, Mumbai. He completed his MBBS from GMC Nagpur and MS in Orthopedics from KM Hospital, during which period he received 3 gold medals. Then he pursued orthopedic fellowship at Medical College of Wisconsin, USA for a year. During that fellowship, he received 2 international awards and also diploma for CCOT, Belgium. He then underwent fellowship in advanced joint replacement and adult reconstruction in Germany and later at Perth, Adelaide and Melbourne in Australia. He is the first Indian to top the international diploma CCOT exam. He has special training in hip and knee revision procedures, hip resurfacing and unicondylar knee replacements. He is well versed with the latest technology in the field, especially minimally invasive surgery, computer navigational surgery, and patient-specific instrumentation. He is a member of the editorial board of many journals. He has published several peer-reviewed publications in national and international journals and has written several books and book chapters. He has received several national and international awards throughout his illustrious academic career. He was selected to represent the medical community in the Beijing Olympic torch relay held in 2008. That's very interesting. Dr. Vaibhav Bagaria, a warm welcome from IMA. Today he'll be talking on knee pain and various treatment strategies. Dr. Vaibhav Bagaria.
So I'll start sharing my screen. Thank you, Dr. Jitesh, Dr. Anil, for inviting me. So I'll be speaking on current strategies in the management of knee pain. Dr. Jitesh has already introduced me, given a very warm welcome. And I thank you, Dr. Jitesh and Dr. Anil and Dr. Chirag, for inviting me for this topic. Now, the knee pain is a very common topic that is often encountered in practice. and I'll take you through what are the current strategies and what changes have happened in last few years in the management of these knee pain. So for us, knee simply means one organ, but actually if you look at the whole knee, it is comprises of many different structures, from the cartilage, the ligaments, the meniscus, and also the bone part of it. So if you'll see that there could be multiple causes of the knee pain, and we must be cognizant of various things that will cause knee pain. So as I said, the knee pain can be caused because of the cartilage, bone, synovium, muscles, ligament, and last but not least, the skin and the superficial structures. And how do we approach this knee pain? We of course take a good history, we do examination. There are imaging modalities available for us to reach a diagnosis. Sometimes we use specialized modalities to reach a conclusion. But I think the basic thing is to think in terms of the location and mechanism of what causes this pain. So this is just a brief overview of multiple causes of knee pain that can happen. And if you start from the outside of the knee, the foremost is the IT band. It runs at the side of the knee and can cause the pain at the side of the hip or at the patella. At the front of the knee, there could be quadriceps tendinopathy. On the outside, it could be a meniscus or even an arthritis. On the inside, again, it could be a meniscus, a medial collateral ligament injury, an arthritis. If you look beneath the kneecap, it could be osculolator, osteochondritis dissecans, jumper's knee, or some kind of patellofemoral instability. And the pain at the bank anterior aspect could be because of the chondromalacia, which means the thinning of the cartilage under the patella. It could be defect of the patellar tracking, or it could also be the arthritis of the patellofemoral junction and bursitis in that area. Now, when we look at knee pain, we must ask first history is there any history of trauma, whether it is traumatic and non-traumatic. Trauma, of course, if you have, it's very clear cut that you need to take an X-ray or an MRI. However, if it is non-traumatic, which may happen many times in our practice, we have to look whether it is coming from within the knee or whether it is coming from an external source. And again, within the knee, it can be because of actually inside the knee, which is called as intra-articular, or it could be peri-articular. Now, intra-articular could be structural, which means there is a mechanical problem. And how the history would be, the patient will classically say that the pain is with movement, and the moment he rests, the pain goes away. So that is how you distinguish whether it is a mechanical thing or a non-mechanical thing. A non-mechanical thing, which is more likely to be inflammatory, will be pain with the rest and also with the activity. On the other hand, if you look at the other thing, which is periarticular, you'll have a focal pain, and the differential diagnosis would be based upon the location of it. External cause, as we'll see in the slides coming forward, it could be referred pain from different areas. Now, this is a very busy slide, but if you had this slide, you will be able to kind of achieve 90% accuracy in your diagnostic without actually needing any X-ray or an MRI. And as I said, first is the traumatic, non-traumatic, and this is all that I've explained is in this slide. So if you had an algorithm for assessing a knee pain, you will be able to reach a very conclusive diagnosis in your practice, even without needing to even see an X-ray or an MRI for such patients. As I said, we must not forget the external causes, which could be flat foot, or it could be the referred pain from the hip or from the spine. And it is also important to have these pictures in your mind to represent various areas or various dermata from where the pain can be referred. We've already talked about the periarticular cause, and often, as I said, our focus is at knee, but we miss out on these important structures which are in and around knee and may be an important cause for the knee pain. Now, majority of our problem from knee starts from the intra-articular thing, and it could be intra-articular, could be cartilage problems, it could be meniscal problem, it could be ligament problem, or it could be synovial. So these constitute the most important chunk for knee pain. Now, we'll start one by one, and this is meniscus. So meniscus acts as a shock absorber between the two bones, and it acts like a cushion. So this is how a meniscal tear will look like. And of course, there are different types and pattern of meniscal tear, and depending on the pattern, we either and most so when you have a meniscal tear, it is important to distinguish whether it is traumatic or whether it is age related. For a traumatic meniscus, we need to kind of do an arthroscopy. Yeah, so we need to do an arthroscopy to kind of identify what kind of tear is it, and the treatment could either be a meniscectomy or a meniscal repair depending on the nature of the tear. The second issue is the ligament injury, which happens here. If you see, that's the commonest ligament to get injured, which is the anterior cruciate ligament. And that's the MRI on the right side. The first MRI on the right side shows how the normal ACL looks. And the MRI beside that will show you if the ACL is torn. That's the MRI picture for that. So normal ACL will have a clean black line in that area.
अभी लाया
And,
वो हाँ
yeah, so
ये बना गया
Mr. Host, to meet everyone, please.
इसमें डालेगी ना
Chirag, mute
Mute
all.
everyone.
yeah. So basically, if the ligament is there, so you'll see a thick back line, and if there is no ligament, you'll see that there is the ligament is completely gone. This is how it looks like on the arthroscopy. That the torn ACL, you'll see that instead of a strong band, there will be a hazy structure there. Now the second point is the cartilage tear, and as you can see, this is again an arthroscopic image, and the image from within the joint, and the normal glistening surface of the articular cartilage is completely gone, and you can see the bare bone there. So this wear off of the cartilage is called as arthritis, and basically if you look at the arthritis, again there can be subtypes of the arthritis, which broadly can be classified into three groups: osteoarthritis, inflammatory arthritis, or a septic arthritis. So inflammatory arthritis is a very large group of condition comprising of 100 subtypes, but three main common types are rheumatoid arthritis, psoriatic arthritis, and crystal induced arthritis, which could be gout and pseudogout. Osteoarthritis, on the other hand, is a degeneration of the joint cartilage, and it could be either primary or it could be secondary to injury or wearing off of the joint. And the third and the rare group is the septic arthritis, which is basically because of the infection of the joint. Now, if you look at the management of osteoarthritis, and I'm not talking about the septic arthritis here, I'm primarily now talking about osteoarthritis, which forms the bulk of our general practice and our orthopedic practice. The treatment include bracing, diet, medication, injection. We can offer a patient surgery in form of arthroscopy or knee replacement. And that is where all the paradigm shift is happening, and the main focus of this talk today is. So this is a simple brace that we give. Now, there are different types of braces available in the market, but it is important to choose the right brace, because if you don't give a right brace, the patient may end up being worse than what they are. So this is a typical OA reaction brace in which the load is redistributed in the joint. So most people who have got age-related arthritis will have wearing of the cartilage on the inner side of your knee. So by this structure that is there, if you look at this mesh structure, the vector of the force shifts from the inner side and gets redistributed on the outer side. So when you have an osteoarthritis, the kneecap of course gives a mental satisfaction to patient, but the real benefit or the real science comes in where you prescribe the right brace which transfers the load from the inner aspect to the outer aspect of the joint. Nutrition, again, that's an important component in the initial stay in the management, that you should give a diet which is calcium rich, which can offer omega-3 fatty acids, because at least in the initial stage, they make a difference in terms of preventing or further damage to the joint. There is some role of pharmacotherapy in this. The role is not conclusive, but some people do benefit from receiving stuff like glucosamine, chondroitin, rose oil extract. So there are various types of joint supplement, fish oils, which help prevent further degeneration, especially when given early in the stage of arthritis. Now, the best thing is in all stages of arthritis is to maintain the bones and the muscle strength. And there are very few simple exercises that needs to be done. And I'll just mention three of those, which is the quadriceps strengthening, which is the primary exercise, straight leg raising, and hip adduction, which strengthens the inner side of your muscles of your knee joint. So if your patients did these three exercises, there would be a large amount of benefit to them. Yoga also makes a big difference, and I think improving your core strength helps maintain and offload your joint. So that should again be an important part of the management of the knee pain. So injections, there are two injections that we give for knee arthritis, and most of them are given for an acute inflammation in osteoarthritis. One is the Synvisc injection, which acts more like a lubricant, and the second is sometimes we give steroids. The use of steroid has gone down significantly of because of its side effect, and because if not given in a sterile environment, they may risk infection at a later date. But acute exacerbation of osteoarthritis, I still think that steroids have a role. And for mild to moderate osteoarthritis, even the gel injection, which is the Synvisc injection, plays an important role to postpone the need for a surgical intervention. As I said, sometimes we do an arthroscopy for these cartilage defect, but they are done mainly for the younger patient who have got a contained defect. So if you look here, all the rest of the cartilage seems quite whitish, but only there is a defect, which is probably because of a trauma or an injury. In that case, we do cartilage procedures, which are a single stage bone marrow aspirate concentrate injection, micro drilling, or what is called as cartilage transfer or OATS procedure. So that's done and reserved for young patients. But the ultimate solution or the end point for all degenerative osteoarthritis is total knee replacement. It is done with an artificial joint made prosthesis, which is made of plastic and metal combination. And it's been there for many years. It has shown excellent results. And this is how a joint replacement implant looks like. There is a femoral component, there is a tibial component, and there is a polyethylene liner in between, which acts like cushion. So this is how a surgery is done. There is a midline incision. The bone is shaped in a particular direction, and then the implants are inserted. So that's how an intraoperative picture looks like. And this is a very small video to kind of tell you how this happens. So you can see that there is all the red part is a degenerated joint, and this is how the incision is made. You look inside the joint to kind of know what is happening there, and once that's there, you can see and inspect, and then you make cuts to make it suit the size of your implant. That's the femoral cut, that's the tibial cut, and finally, once that's done, your implants are cemented on these surface. So this is the femoral component, this is the tibial component, and you'll see that the worn out surface is now resurfaced. Occasionally, you'll also have to do a kneecap thing, so that's there. So that's how a replaced knee joint looks like. That's how the x-rays look like. That's the day one x-ray, and you'll see the femoral and tibial component. And usual course of the improvement is on day one, most patients are allowed to stand, bend, and sit out in their chair. They may take a few steps depending on their medical condition. On day two, definitely they'll walk with aids, maybe the whole corridor. Nowadays, most patients go home either on day two or day three. But if they are in the hospital, between day two to day five, we teach them stair climbing. As I said, most patients will go home on the day two. Some patients, because of the medical reason, may require to be in the hospital for a longer time. And by week 6, most people should be walking unaided and also driving. People ask me what is the complete time for recovery. I would say between 10 to 12 weeks. Again, it's quite individual, and some people resume working between 3 to 4 weeks, and some people takes up to 3 months to get back to absolute normal, pre-operative, or even the normal stage. So people ask what's the benefit of TKR compared to other things. Of course, it does relieve pain that does not respond to other treatment option.
Can't hear.
Hello, am I audible now? Hello.
Yes, sir, you are audible.
Yes, sir. Yes, sir, you are audible.
Yeah. So there is a pain reduction in 90 to 95% patient. It reduces stiffness and improves joint movement, increases walking ability, and improves the shape of the joint. It improves the alignment. Now, what has changed? So we have seen that there demographic change is happening in the entire country. We are living longer and longer. We are slightly more obese than what we were, and there's an altered disease incidence in terms of younger people being affected by this arthritis. So how has the expectation changed? In 60s and 70s, we would be happy if our patient said if there is pain relief. In 80s and 90s, we operated for pain and aimed to provide good outcome. Today, we not only operate for pain, good outcome, but also to maintain the patient activity profile. And that's where all the development is happening and the paradigm shift is happening. to give the patient the activity profile that suits their needs. So what changes have happened? We have changed the design of implant to give them more bending. We have now come to a point where we are thinking in terms of male and female implant. We are using technology like computer navigation, patient-specific instrumentation, iPad-based pinless navigation, and finally the new kid on the block, which is the robotic surgery. So as I said, flexion or deep sitting is an important part of our lives, and the newer implant designs. If you look at this, is a bit of technical slide, but if you see how the companies have changed their shape of design to change it from the J curve, and with a small extra cut, we have ensured that we can get a better flexion range. However, it does so with these design, people can get up to 150-degree flexion, but the challenge is that this extra bending comes at a cost, and it is the cost of getting additional wear, increasing the contact stresses, some pain on the anterior knee joint, and sometimes they may compromise the knee stability. So we get something, we lose something. But the design is out there for us to use, especially in patients who demand a very high degree of flexion. We offer them this design. As I said, we are looking into more and more gender specific profile of the implant, and this is how the design again has changed of the implant to cater to the male and female subset of the population. So it's been done. If you look at the pink one and the blue one, so they have taken the anthropometric data from the male and female population and modified design so that they mimic the natural movement of the knee, thus by improving the patient outcome and patient's experience with the surgery. As I said, technology is touching all aspects of our life, and I think there have been technological advancement in last 20, 30 years that have made knee replacement even more successful, and one of them was computer navigation. So the whole idea was to improve the alignment of the knee joint. It is believed that the more aligned the knee joint is, the better the long-term outcome is, both in terms of patient satisfaction and the longevity of the implant. So the navigation was used to do this. It is quite similar to GPS, and as it said, that it helps achieve better alignment, and also one medical additional advantage is that it reduces the incidence of fat embolism syndrome. However, the computer navigation has come as a mixed bag. It is contrary to what was expected of computers. With computers in our mobile phone, we always want them to be fast, cheap, and easy to use. But with the use of navigation, we spend more time. It added to our inventory, and it was expensive and required maintenance. And surprisingly, although we improved the alignment, it did not significantly improve any clinical outcome in long-term studies. So that's why the computer navigation was considered as a mixed bag. Then came in patient-specific implant and instrumentation with the premise that when we go to a tailor shop, we get everything customized from the neck size to the cuff size to our length. But when we choose knee implants or knee instrumentation, there are fixed sizes of implants available, and that changed with modern technique of 3D printing, in which the patient's MRI and CT data was used to customize the instrumentation as per the need of the patient's anatomy. So these are the patient specific instrumentation that come in. So instead of the bulky instrument sets, today we get these two jigs which can be used to do the surgery specifically meant for the patients. It did improve accuracy, it reduced the operative time, and again, because there was no intramedullary rod, there was less incidence of fat embolism. It was a simple setup with minimal instrumentation and reduced the sterilization and inventory cost. Now the other advantage, so simultaneously you will see that there are different field of research that are going on. Another area that progressed was eye assist. It's also called as pinless navigation. It was a navigation without the current drawback. It used iPad-like device for improving accuracy and combined the gyrometric and wireless navigation so that the bulky machines are replaced. It's something very similar to what is used in most advanced jet. And we at Reliance Foundation Hospital were proud to have done one of the first simultaneous bilateral ISS. And I'll show you a small video with this. So this is a video of how the surgery is being done with these little devices. You'll see these are the small batteries that we use to augment. And then you'll see that this is a small navigation thing that we have attached to the patient's thing. We are calibrating and aligning it to the space and the operating room and the patient's anatomy. And with this, once we have done that, you'll see on a console what is the degree of cut that we need to make. So these two things are very small devices. And you'll see that once we have calibrated our cuts and the direction that we need to make the cuts on, we'll see on a console what is the direction, what is the cut, and what is our accuracy of the cut. You'll see this is how valgus and what is the degree of the cut. We'll see it for both the sides. So that's how these small devices are used to improvise our cutting abilities and giving a more accurate result. Now, the final thing is the robotic assisted surgery, and we are in talks. We have done a few robotic surgeries now at Reliance Hospital, and we'll be soon having our robot of our own. And this again is an advancement where the surgeon remains the decision maker, but the accuracy of implementation is done by robotic technology. So I think that will again be a very paradigm shift, and we are very excited for in procuring this technology to the hospital. We also now have technology to only replace the part which is affected, which is also called as partial knee replacement. And I think again that is there for some time. And with the improved design, I think certain set of population whom we used to defer earlier can be managed with half or partial knee replacement, only replacing the part which has been affected and preserving most of the ligaments that are important to the proprioception and the strength of the knee. A few cases that you can just to kind of complete this. So if you look, this is a valgus knee. So, and where we have replaced, and you can see how the alignment has become completely neutral. And similarly, this is another case where you have got completely bowed knees or varus knees. They've been corrected and aligned clinically in a proper alignment. So that's the advantage apart from the pain relief that you can get correction of deformities, even severe deformities like this during the surgery. Of course, there are myths related to the procedure. Most people believe that while hip replacement is very successful, knee replacement is not as successful and experimental. There is also a lot of myth about the longevity of implant, which people believe last only 8 to 10 years, at the most 15 years, which is again untrue because the modern implant design sometimes lasts up to 30 to 35 years. And that it cannot be done in the obese patient because of the weight. Of course, the cost is a subjective issue, and people feel that after knee replacement they have to be bedridden for a very long time. And last but not least, people believe that knee replacement means that you are actually completely taking out the knee and putting a new knee. The correct term should have been knee resurfacing, because what we do actually is just to remove and put in the new implant on the one-off surface. So just a word about our orthopedic team at Reliance Hospital. Ours is a dedicated team with niche focus areas to ensure optimal patient care and have one of the most equipped operating room. But the important thing is the way we approach our patients, which is quite protocolized with constant key performance indicator monitoring, including the infections, including their length of stay, including the patient satisfaction. And the teaching and research coupled with our clinical side is a key focus for our department. These are few of the papers that we have published in last 6 to 8 months. And as an active department, we published in robotic knee, artificial intelligence, I think, because both of these will be key driver. The other thing is, you'll see this interesting article that we did, which is basically the measuring the anthropometry of Indian knees to make it more customized to Indian population. The other one is a unique technique again that we described, which is the direct adductor canal block, which is a pain relief measure. And I think that's a very important part of recovery of the patient. And no talk today can be complete without talking about COVID. We've written about how safety measures that we took during this COVID time to kind of ensure that our patients remain safe during this procedure and are not denied the services that they deserve to be. Where we stand today, there are many new knee designs and technology entering the field. All of them are aimed at improving patient outcomes. We believe that the robotics and artificial intelligence are likely to be game changer. Our implant designs are seeing continuous improvement. The focus is on short stay and better pain control. But as a last word, technique, technology, and teamwork are the key. And we are aiming to combine all these three for an optimal patient care and happy patients. So I'll thank you. Thanks once again, Dr. Sujata Nissa, Dr. Pankaj, and Dr. Anil. It was really a pleasure giving this talk to all of you and interacting with you. And I'll thank you and welcome any questions that audience may have in this respect.
Thank you very much, Dr. Vaibhav. Very explanatory lecture. And I don't think there are any questions from the panelists. There are no questions in the question answer box.
So I have a question to ask Vaibhav.
Yes, sir.
If I assist and robotic surgery are combined, I think you have to take a back seat.
Eventually, we'll all have to, sir. Eventually, we'll all have to, whether we like it or not. But one thing that will remain constant is our decision-making ability, and that is, I think, that is what describes us as humans. I think what we choose
that will never.
define us, and I think that never can be taken away from us. Of course, you'll see the airlines industry again; it's become autopilot and everything, but you still need pilot because in the crucial time, that one nick of second decision makes the big difference. And I think that it will still remain with us. We'll be the last frontiers. Everything else will, but doctors will at least be the last frontiers. I can confidently say that.
That's the solace. Thank you.
That's the solace.
Thank you, Dr. Vaibhav. And
Thank
we
you.
just forgot to mention that Dr. Vaibhav is the head of the orthopedic department at Sir H.N. Reliance Hospital.
Thank you.
Wow. Thanks a lot.
Thank you, Thank
now I request Dr. Girish Lad to propose a vote of thanks.
Can you hear me?
Yes, sir.
Yes.
Good afternoon, all. I would like to thank our speakers of today's webinar, Dr. A.P. Phatak, Dr. Ian Pinto, Dr. Suresh Advani, Dr. Ashok Mahashur, Dr. Paresh Ved, and Dr. Vaibhav Pagaria. Our knowledge partners for the day, GlaxoSmithKline Pharmaceuticals Limited, Mylan Pharmaceuticals Limited, Menzi Pharmaceuticals Private Limited, Novartis Healthcare Private Limited, and Sir H.N. Reliance Foundation Hospital. Mr. Dipen Mehta and Mr. Chirag from DigiSheet, who have given us platform for this webinar and handled all the technical details at the same time. I also thank all the delegates for participating in the webinar to make it a grand success. Thank you very much.